Hello and a very good evening to everyone. This is our pleasure to have Dr. P C Mahapatra once again with us after a gap of a few weeks. Dr. Mahapatra, as you know, um, is a very good speaker and a revered teacher for all of us. So everyone is keen to listen to Dr. P C Mahapatra, and today he has brought a fantastic topic for us, and that is ectopic pregnancy, the surgical options for that, and what are the tips and tricks for the same. So in this E-Gurukul series, the series number 12, we would like to ask Dr. PC Mahapatra to share his views and his experience on the same. Dr. PC Mahapatra, please.
Thank you, Dr. Diwan, Mr. Alad, and whole team of Juventus for initiating this E-Gurukul program and continuing all this program. And I welcome everybody, the viewers, for this teaching program. And I think I thank the Juventus people for this academic partnership for my fellow gynecologist. And I'm sorry that we have taken a pause of about 2 months since last episode of 11th episode of this teaching program of E-Gurukul, which is a Juventus initiative focusing on surgical skill transfer and solving clinical dilemmas. I thought many of my fellow gynecologists must have wondered that I'm in the COVID hospital or in the ventilator, and then I've recovered after 2 months. It's wrong. Absolutely, I'm fit. I'm always physically fit, but digitally very weak. And I intentionally deferred the program because of the real problem and magnitude of the problem of the second wave of COVID, and our doctors are so busy in that, and not only busy, their personal relations and all that have suffered, and I have seen the pains of those people, and that is the purpose for which I took a break. And again I welcome all of you to this episode of the Juventus initiative of Gurukul, where it's absolutely, as you know, we are doing a focused program on that. And this program, I think it's particularly subjected to a particular aspect. And today is one of the very common aspect which every clinicians face it for that. This subject is very close to my heart. Not only that it's common, but I have seen the evolution of this subject. The day I started practicing gynecology way back in 1980s, and since then I have seen the evolution of how it has gone up, how we have changed, how the diagnostic parameters have changed, how the management protocol has changed, how the mortality and morbidity has been reduced to considerable extent. And therefore, I cannot forget one of the unforgettable memories of mine way back in 1986 when I was a lecturer in SC Medical College doing my emergency duties in that time. I recollect, still I remember the patient, 28 years, para 1, missed period 7 weeks, UPT positive. At that time, beta ICG was not available, UPT, urine pregnancy test. Presented in emergency hour. I was on duty, and in emergency hour in the labor room, she presented with features of peripheral circulatory failure, pulse not palpable, BP not recordable, severe pallor, gasping, abdomen is distended, and there was no option. At that time, we only rely on our clinical sense and diagnosed clinically as acute rupture, ectopic. Resuscitated immediately with my postgraduates and my team, started resuscitative measures with IV fluids, plasma expanders, then requisition for blood. 3 units I've sent with the party, and immediately I transferred the patient to the OT, and urgent call to the anesthetist to attend that so that we could save the life of the patient. Anesthetist also obliged me and came and on duty, the anesthetist examined the patient but refused to give anesthesia, as he told that the death is imminent. This patient is gasping, BP is not recordable. I can't give an anesthesia to such patients. So I thought I will declare the death. It's really a horrifying moment for me. And absolutely, at that time, two of my postgraduates told me, "Sir, whatever you do, something for that. We will try." Then a thought of alternative option came to me. I decided that without anesthesia, I will do some intervention. I know that the patient is going to die, but I thought of, decided to do a colpotomy without anesthesia. Colpotomy was done, lithotomy position under anesthesia, without anesthesia. I did the colpotomy, and approximately 2 liters of blood and blood clots drained out. Then I put a speculum and retraction with the sponge holding forceps. I retracted the uterus, putting a speculum in that same patient. And fortunately, as if God has helped me in delivering the right femoral end. And the right femoral end was visible, and along with the dilated ampullary portion, and with the sponge holding forceps, I found that there was a rupture and active bleeding from the ampullary portion. So immediately I did a salpingectomy, sutured it, and but without visualizing any pelvic structures. Right ovary was not visualized. Only the tube and the ruptured end I could see, and I could I could ligate it, and then colpotomy wound, closed it with a corrugated rubber drain. At that time, even the Ramson's synthetic drain was not available. Only the old fashion of corrugated rubber drain was there. I put a rubber drain in the middle for a continuous draining. And after that, immediately I found that when you clamp the bleeding point and bleeding is arrested, I think within minutes, the thready radial pulse could be palpable. Patient positioned with oxygen and mask. And after 15 minutes, only 1 unit of AB positive blood could be brought by the attendant. They were helpless. AB positive blood was not available, and therefore we have given a requisition of 3 units, but they could bring 1 unit of AB positive blood and transfused immediately. So what I find, I thought, I know my blood group was AB positive. I immediately rushed to the blood bank, donated 2 units of AB positive blood, and immediately brought it and transfused it. Now, BP was recordable 80/50, pulse was 140 per minute after 2 units of transfusion. I was so happy that as if my purpose is solved. Vitals was stabilized after 4 hours, and post-op period was uneventful. Patient was discharged with smiling face on 6th post-op day. This is the memories of 35 years ago. One of the memorable and pleasurable case in my life, where I was the surgeon and I donated the blood to save the life, and life was saved. Clinical diagnosis was the only option in pre-sonographic and biochemical era. At that time, we don't have any option. And dictum at that time, one should be ectopic minded to diagnose. And any slightest suspicion of ectopic, you do an exploratory laparotomy. So exploratory laparotomy is preferable than non-interference due to high mortality in yesteryears. Laparoscopy was not available, sonography was not available. So slightest suspicion. They say at that time the dictum was, if you doing an exploratory laparotomy and finding nothing is preferable than not doing a laparotomy when there is a suspicion of ectopic. If at all there is there, 100% mortality would be there. So saving life is of paramount importance. An alternative option could be thought of. Decision for immediate colpotomy and arresting bleeding and multiple blood transfusion aggressively with God's blessing could save the life. And I cannot forget these unforgettable memories of my life, of my experience. And therefore, ladies and gentlemen and viewer gynecologist, fellow gynecologist of mine, ectopic pregnancy, I've decided that it's so close to my heart, surgical options, tips and tricks, solving clinical dilemmas. We have a lot of change. For the last couple of years, decades of practice in obstetrics and gynecology, I can reveal some of my own personal experiences and evolution. And I have put few of my all the series of cases, varieties of cases which I have seen since I became a gynecologist till date. I'm continuing to see cases and all that, and putting before you for sharing. You must have, all of you must have observed the same. Even 4 days back, I did one case which I have put it and shown it today. And every day we are learning, and varieties we see as we grow older and older. So ectopic pregnancy, what we know. Just so I have divided my E-Gurukul program into two main aspects. I will brief about the different aspects of ectopic pregnancy. Then we'll go for the situational analysis and clinical dilemmas and try to solve them. So what we know of ectopic pregnancy, any pregnancy implanted outside of the endometrial cavity, is very simple, but it's the main cause of maternal death in first trimester. Clinically, there are three triads: pain, vaginal bleeding, amenorrhea are the major three symptomatology, clinical symptomatology. And tubal pregnancy comprising around 98%. 98% of the ectopic pregnancy are tubal, and rest 2% are non-tubal. I will just disclose what are the non-tubal entities. And non-tubal are appearing more commonly because the diagnostic gadgets are now developing more and more and utilizing them. So non-tubal like cervical, cesarean scar pregnancy, ovarian pregnancy, abdominal pregnancy, and many, many rare varieties we see. And last but not the least, since last 1 decade or so, a new concept, a new terminology has come up, PUL, pregnancy of unknown location. This was not seen. We are not known since last 1 decade. The literature came, pregnancy of unknown location. When the biochemical methods have proved that it's a pregnancy, but biophysical methods like ultrasound and imaging sciences failed to demonstrate. Only the beta ICG is positive. We do not know whether it's an intrauterine is not there, extrauterine not there. We put it an emerging concept of pregnancy of unknown location, which is really important to distinguish it as far as treatment is concerned. Now, there are many pitfalls in diagnosis, and again, I must emphasize, one must be ectopic minded to diagnose. You think of ectopic, apply your clinical sense, and take help of the gadgets, and you can reach to about approximately nearly 100% of the cases. So there is a decline in exploratory laparotomy with the newer diagnostic tools like sonography and beta. These are the two tools which have revolutionized the diagnosis of ectopic pregnancy: sonography and beta ECG. So one biophysical and one biochemical. And therefore, exploratory laparotomy no longer we are advising, which about 3-4 decades before any suspicion, we are doing exploratory laparotomy, and then if there is nothing, we close it. Early diagnosis saves life. That's important. And surgical modality is the mainstay. Lawson Tate, regard and salute to the great person Lawson Tate. Way back in 1888, he was the first person to demonstrate that surgery saves life, and is the father of surgical management of ectopic pregnancy, doing a salpingectomy, open salpingectomy. In 42 cases, he could save at least 38 cases. And that was the remarkable point for which the surgical modality is important. We have revolutionized, we have improvised the different technology of surgical intervention. We are doing it shift from the laparotomy to the minimal invasive surgery for that. But laparoscopic approach is the gold standard. It's not for diagnosis, but for therapy. Diagnosis, sonography, and beta ECG still prevails. And medical management in select cases, where rare types, atypical presentations like intramural pregnancy, pregnancy after hysterectomy. It was a surprise, pregnancy after hysterectomy, and rare cases, case reports are seen nowadays. Now, coming to the risk factors. The major risk factors I will enumerate. We know that PID, pelvic inflammatory disease. Here we must know that what are the pelvic inflammatory diseases which are more concerned for that. So any pelvic infection of a subclinical nature which keeps the tube partially patent, I think that is the case where it is likely to be an ectopic pregnancy. Gonococcal infection or gonococcal salpingitis earlier was very common, where the ectopic is least because it causes a terminal salping, the tubes are closed. So it causes the hydrosalpings or pyosalpings where the tubes are patent up till the femoral end, and that is closed. Femoral end is closed. And that doesn't cause the ectopic pregnancy. But chlamydia trachomatis or a multimicrobial organisms with antibiotics, it has covered and healed. And there is agglutination of the internal cilia and the internal diameter, internal epithelium of the tube, that is more prone to develop people where the ectopic pregnancy because the fertilized ovum passes through the tube, but it doesn't have an ability to cross over the tube to the uterus. Tubal surgery. Now, tubal surgery is starting from infertility promoting surgery, cannulation, hysteroscopy cannulation, salpingolysis, recanalization. I think these are the cases where it's more common. Previous conservative surgery for ectopic, you have done like salpingotomy, and of course, sterilization. The tubectomy. Tubectomy is one cause of this. And these are the cases where the tubectomy, partial clamp of the tube, there is a small gap opening of the tube which is there through which the pregnancy can be possible for that. We have seen very many cases of post-tubectomy tubal pregnancy also. Second and third important is altered tubal anatomy. Altered tubal anatomy either because of the peritubal adhesions or a congenitally elongated tube. These could be one of the cause of ectopic pregnancy, including a transperitoneal migration of the ovum. On one side, the opposite side, it takes a long time, and that can cause ectopic pregnancy. And of course, nowadays, the ART is growing. Assisted reproductive technology, IVF, IUI, all these are growing like anything. And this is one of the important cause of the ectopic pregnancy also. Apart from it, the others like smoking, prior medical or surgical abortion, age more than 40 years, history of infertility, prior ectopic pregnancy, and IUD use more commonly the progesterone use, progesterone component causes a decrease of tubal motility and causes is the cause of ectopic pregnancy. Now, as far as diagnosis is concerned, for the clinician's perspective, there are three modalities of presentation. First modality is asymptomatic, purely asymptomatic. Second is symptoms, the classical three symptomatology. Third is acute rupture, tubal rupture. So asymptomatic, what are those? Early detection. Nowadays it is possible. Early detection by TVS and beta HCG. These are some of the special cases where you do a routine ultrasound early in pregnancy. Say, for example, previous history of ectopic. We want to locate the location of the pregnancy this time. So early pregnancy. Otherwise, to diagnose pregnancy, UPT positive is enough for that. But these are the cases where you want to locate whether it's intrauterine or extrauterine because the possibility of ectopic is more. Conceiving following investigation for infertility, they are very eager. And ART pregnancy, we want to know earlier and all that. And nowadays, the elite women or educated women wants to confirm it by sonography, not by UPT. And routinely in first trimester, in early pregnancy also, early weeks, they do a sonography. So accidental detection of ectopic pregnancy can be possible here before any symptoms manifest. Second important is the clinical triad of symptomatology. Characteristics, vaginal spotting, bleeding. Not much. Bleeding is not heavy. Small amount of bleeding, but more of pain. Pain is a variable patterns. Pain either unilateral or in the lower abdomen or in the upper abdomen, depending on the type of the ectopic. And that pain, persisting pain, not relieved with the conventional analgesics. Then third is amenorrhea. This amenorrhea of variable duration, very short period of amenorrhea to as long as 12 weeks to 14 weeks of amenorrhea also we find it. But absence of amenorrhea doesn't exclude ectopic. So many cases the pregnancy could be there. We know that before menses also the fertilized ovum is there and there could be a biochemical pregnancy for that. And therefore, with a very either a short history of amenorrhea or without any missed period also, they present with the ectopic pregnancy. These are all pitfalls in diagnosis. Third important is a more serious threat and taking life is tubal rupture and presenting with the severe acute abdominal pain, tenderness, distension, pallor, syncopal attacks, and signs of shock, as I have told this. So these are the three different modalities of presentation for that. Now, diagnostic tool. Again, I will emphasize that these two have revolutionized the diagnosis. Ultrasonography and serum beta HCG. We were thinking earlier when ultrasound came, the ultrasound is diagnostic. Then we thought, similar picture, this diagnostic accuracy of ultrasound during that time was about 60 to 70%. But when the serum beta HCG was available, ELISA technique was available everywhere and all that, and quantitative estimation of serum beta HCG is more important than the urine test. So serum beta HCG gives an accuracy of about 99 to 100%, and ultrasound combiningly with that almost about 100% diagnosis can be possible if you combine with that. So if serum beta HCG is less than 2, we can confidently say, even with sonographic appearance of adnexal lump, we can confidently say that it is non-pregnant, it's not ectopic for that. And therefore, serum beta HCG is so sensitive and aid to the diagnosis of ultrasound for that. And others, diagnostic laparoscopy. Before the era, we are using the diagnostic laparoscopy for confirmation also when laparoscopy came forward. But it's an invasive test. Nowadays, less than 5% of the cases will require diagnostic laparoscopy because almost many cases, majority of the cases will be diagnosed by non-invasive methods of these two. Choledosynthesis, again, I remember when nothing was available, patient with acute pain and all that were there. We used to do a choledosynthesis and aspirate whether the blood was there or not. In acute ectopic, we are successful. We get typical cervical motion tenderness, fullness in the fornix, and put a needle and find out the blood. But in a chronic ectopic, when the blood clots are there, even if they're ectopic, they fail to get it for them. Third is serum progesterone. Serum progesterone is not at all diagnostic of ectopic, but at least the level below 5 can say that is a non-pregnant state. That can be justified. But otherwise, serum progesterone is not that sensitive test for that. Last is the endometrial biopsy and histopathology, or the aspiration cytology, that can know. That is only can exclude pregnancy of unknown location with intrauterine pregnancy, already expelled pregnancy, and you can find the trophoblast and all that. If you find that, you can say that it is possibly intrauterine pregnancy. Otherwise, it is not going to help in the diagnosis improper. So in sonography, what are the things you have to see? There are three things you have to see: the cavity, uterine cavity, and transvaginal sonography is very important. Cavity, adnexa, and the peritoneal cavity. So in the cavity, earlier we focus attention that whether cavity is endometrium thickness is normal or not. Now, more concern of finding out the non-tubal pregnancy, and therefore you must be very meticulous in assessing the uterine cavity, including the cornu. If there is a previous cesarean section, the cesarean scar, the cervical canal, all these. So as we were more meticulous, you diagnose more commonly for that. Otherwise, you ignore. So these are some of the special points for which the sonographer, or you people, a gynecologist doing ultrasound, should focus on that. Adnexa, what you see? Adnexa, live embryo, gestational sac, fetal node. It's very easy to diagnose this. So confirmation. And complex mass in majority of the cases where we cannot see the whether you diagnose. Because complex mass could be any benign gynecological conditions other than ectopic. But this complex mass with a ring of fire, that could aid to a possibility of ectopic, and if it is combined with beta HCG, the sensitivity goes up to 100%. And then the fluid and blood in the cul-de-sac, about 50 ml of blood collection in the peritoneal cavity, you can detect in the cul-de-sac. And when we find the paracolic goiter and subdiaphragmatic hemorrhage, bleeding, the bleeding is more than 800 ml to 1000 ml for that. And therefore, that can be clearly distinguished. The only point is that you should be distinguishing the fluid, the blood with the serous fluid for that. That's important. Echogenic means, or a mixed, some part there is a blood clots and all that. you can easily diagnose for that. And therefore, sonography, good machines, real-time sonography, and high-resolution machine, as well as a high-resolution man who is doing that is important. The man and machine who are there, man will interpret and machine will give information for that. So these are characteristic sonographic findings. So what are the potential outcomes after sonography? What are the outcomes you get it? There are 5 outcomes we get it. First, either you diagnose definite ectopic pregnancy. How can you say that it's a definite ectopic pregnancy? If you can find extrauterine gestational sac, yolk sac, or embryo with cardiac activity and uterine cavity is empty, 100% you can diagnose that this is a definite ectopic pregnancy. Probable ectopic pregnancy is an inhomogeneous adnexal mass or extrauterine halo that gives rise to probable ectopic pregnancy. You have to correlate with the beta ICG. Definite intrauterine pregnancy, when you get it, clear cut the gestational sac. I think this is very, very important to distinguish pseudo gestational sac from non-ectopic. So this characteristic gestational sac, the sac margin, the wall is very, very important. Demonstration of yolk sac and embryo with or without fetal activity, definite intrauterine pregnancy. And probable intrauterine pregnancy, as I've already told, intrauterine echogenic sac could be there, deformed, or increased endometrial thickness. Thickness of the endometrium is 14 to 16 millimeter. That could be an early intrauterine pregnancy. So these are all probable intrauterine pregnancy. And last, pregnancy of unknown location, which is non-diagnostic. We cannot get anything out of it also. What about serum beta ICG? There are 2 important things in serum beta ICG: initial value and serial beta. Initial value varies from individual to individual. We know that if there is an ectopic pregnancy, initial value will be less than intrauterine pregnancy. But the serial beta ICG is more important. The doubling time is more important to prove that it is a growing fetus and intrauterine pregnancy. Although a live embryo or a twin pregnancy are the pitfalls in diagnosis, but this is important. Third important, correlation with the ultrasound finding is what is known as discriminatory zone. The level of beta ICG where you can find a correlation with the gestational sac, with the yolk sac, with the fetal load is correlated with that. So normally with 1500 to 2500 units, the intrauterine pregnancy gestational sac must be visible for that. Around 3500 and more, you can find the yolk sac and then fetal node. So there is a discriminatory zone which is variable for that and correlate with the beta ICG level. If the discriminatory zone is within that and you are not able to find out in sonography, then repeat after 48 hours, doubling time, and then correlate again. When you find again non-appearance earlier could be a clear evidence of intrauterine pregnancy which is visible. So it's a very sensitive biochemical marker of pregnancy state and trophoblastic activity, serum beta ICG. There is no doubt about it. Diagnostic lab, as I have told, it is an invasive test. So it's only hardly 5 to 6% of the cases recorded that diagnostic lab is employed. Only non-compliant patient where they are non-compliant, not going for a follow-up, or a suspected adnexal mass where a diagnostic and therapeutic are implemented for that. So rarely employed because of the diagnostic accuracy of non-invasive tools like sonography and serum beta ICG, which has almost replaced the diagnostic lab as a diagnostic parameter or gadget for ectopic pregnancy. Little bit about pregnancy of unknown location. I have not heard of that earlier. Last 10 years, we are seeing that pregnancy of unknown location. What is a pregnancy of unknown location? Positive pregnancy test with no evidence of either an intrauterine pregnancy or an ectopic pregnancy on transvaginal sonography. So pregnancy of unknown location is a classification, not a final diagnosis. It can change. A pregnancy of unknown location could be a probable intrauterine pregnancy which can come in due course of time. So the possible final outcomes of the follow-up are either a visualized ectopic pregnancy after a few days on follow-up, or a visualized intrauterine pregnancy, or spontaneous resolution with a decreasing beta HCG without treatment, or third or last, persisting pregnancy of unknown location, non-decline, or increasing beta HCG or plateau, non-visualized ectopic pregnancy, or even histopathological evidence of intrauterine pregnancy by doing a endometrial biopsy for that. So these are the cases where the persistent pregnancy of unknown location. So this is a classification, not a final diagnosis, but it can confuse with your ectopic diagnosis, ectopic pregnancy or intrauterine pregnancy. And place of methotrexate is there in the case of persistent pregnancy of unknown location, where methotrexate multiple dose can be given, and then we have seen that everything can be settled within a couple of months. Now, management, broadly three categories of management: expectant management, medical management, and surgical management. Now, expectant management, what is the place of expectant? Very, very limited place of expectant management. Only in few cases where apparently asymptomatic individual and very low initial beta HCG, less than 400, less than 200, like that, and sonography was non-diagnostic. So very low level of beta HCG, non-diagnostic sonographic appearance, and apparently asymptomatic. This is mainly for expecting spontaneous resolution. But these are the cases which will need follow-up, because at certain point of time, you lose the patient. I think after 2 weeks, they will present with some other classical picture of ectopic, and then mortality and morbidity will be much more. Now, medical therapy. I have told that surgical therapy is the mainstay, but there is a place for medical therapy. What are the patient characteristics? This is mainly for patients who are asymptomatic, motivated, and compliant. These three characteristic patients must be there who are suitable for medical therapy. What are the criteria? Initial low beta HCG level, less than 1000 milli unit, ectopic pregnancy size less than 3.5 centimeter, and not in live embryo, absent cardiac activity. So these are the three criteria where you can employ the medical therapy. And of course, the contraindication for the medical therapy, particularly methotrexate, like the liver, the kidney, all these reasons, hematological profile, all these should be normal for that. If there is an impairment, I think these are absolutely contraindicated. And even with the medical therapy, follow-up is absolutely essential. Don't think that it is all going to solve. And maybe that you have given a medical therapy, patient may present with acute symptoms later on for that. So follow-up is absolutely mandatory. Now in medical therapy, methotrexate is the drug of choice, and mainly we use it for either a single dose or a multiple dose schedule. There are various authors, various modalities of management of the medical management of single dose or multiple dose, and you monitor it with the serial beta HCG, and then it can be given. Mifepristone could be an option for that. And nowadays the new drug gefitinib is being tried and under research, which will be superior than methotrexate because the toxicity is less and efficacy is more. This is under trial for that. Now coming to the surgical, I say that surgical is the mainstay of treatment. And gone are the time before the pre-sonographic or pre-beta HCG era, laparotomy was the only method. And now with the minimal invasive surgery, laparoscopy has almost replaced laparotomy for that. So initially, there are the recommended treatment we used to teach students about 10 years back, that what was the method, route, whether laparotomy or laparoscopy in ectopic pregnancy. We divide into two aspects: hemodynamically stable, hemodynamically unstable. In hemodynamically unstable patient, laparoscopy is contraindicated, and laparotomy has to be done in hemodynamically unstable patient. Hemodynamically stable patient, you can go for laparoscopy. But as we grow, as the experience goes, as the anesthetic are more proficient, gadgets are available, yesterday's contraindications are today's indication. And therefore, I don't think now that in unstable patient also, laparoscopy can be used, because if the patient is fit to withstand anesthesia, she is fit to withstand surgery. That is important for that. And therefore, this has changed the situation now, that laparoscopy in the majority of the cases. Now, what are the procedures? In a tubal pregnancy, there are mainly either a conservative procedure of salpingotomy. You cut it and remove the product of conception, remove, and keep the tube intact with or without suturing, or remove the tube. There are several indications for that also, salpingotomy and salpingectomy. Salpingectomy is the preferred treatment, and particularly when the tube has ruptured, damaged tube, and the other contralateral tube is normal. In those particular cases, in recurrent pregnancy, recurrent ectopic pregnancy, or in a post tubectomy patient, salpingectomy is preferable than salpingotomy. But otherwise, salpingotomy could be done, and there is a lot of research, lot of studies on salpingotomy and future pregnancy. Will almost same salpingotomy and salpingectomy. If the other tube is normal, the chances of subsequent intrauterine pregnancy are all same. But there is a possibility of recurrent ectopic and previous salpingotomy. But one important message I will give it, that patients are very, very apprehensive. So if you say that I have done a salpingotomy, I have conserved the tube, even if the tube is functionless, they're psychologically happy. If you say that even you damaged tube, you have removed it, they will ask, sir, you have removed one tube. And as if keeping that tube will be beneficial. I think removal of that tube is important. In a damaged tube, you have removed it. That's much better than that. But it gives a psychological satisfaction that my organ is there, my tube is there. Second important aspect in conjunctive surgery like salpingotomy, there is a risk of about 15% of the cases do present with persistent trophoblastic tissue. And therefore, in all cases, wherever you do a salpingotomy, I will recommend a single dose of methotrexate postoperatively. That's enough. That will take care of this persistent trophoblastic tissue routinely, not in salpingectomy, but salpingotomy. Now, my viewers, my fellow gynecologists, let's come to the reality situation which I have faced. You must have seen more number of cases and varieties of cases which we can share. But this is a platform which I will definitely share my experiences for the last, which I have seen for the last decades of my clinical practice as a gynecology. And that's a duty of mine, to have a surgical skill transfer and try to solve the clinical dilemmas with all of you, my fellow delegates. Now, situation one. This is a 26 years, married 4 years, conceived following ovulation induction, overdue 6 days, UPT positive, very apprehensive, one episode of acute pain abdomen. For abdomen not revealing, internal examination, I can't find anything, uterus size not elicited, but tender fornix as usual. I did a TVS, uterus enlarged, endometrial thickness is 14 millimeter, no gestational sac, right adnexal mass of 3 centimeter, and color Doppler suggestive of increased vascularity, minimal fluid, and beta ICG was 1200 milliinternational unit. With this, I have kept ectopic minded in my brain. I thought of ectopic pregnancy, but still I'm not confirmed. I did a follow-up measurement, and I kept the patient under observation, persisting pain. Repeat beta ICG, I have done it. After 48 hours, 1600, it has gone from 1200 to 1600. Again, I did a scan. No gestational sac, endometrial thickness is 40 millimeter. But two things are important with the minimal fluid and right adnexal mass. These two and persisting of pain prompted me to confirm the diagnosis, and therefore I did a laparoscopy. See the laparoscopic finding of this particular patient. There is a minimal fluid collection in the POD. The left tube and ovary is normal. Uterus is enlarged, congested, and right ovary and tube is normal. And I find the right ovary is larger than the left ovary, and right ovary there is a corpus luteum. That has confused that it is a adnexal lump for that. And that the main principle where you are having a suspicion, don't put uterine manipulator. Remember this. So minimal handling, don't handle the uterus also. And that I did that. I didn't find anything. So what I will do? Next step. So this is a laparoscopy finding uterus enlarged, congested, UV space normal, POD minimal stock colored fluid, both tubes normal, right ovary enlarged, adherent to cornu with corpus luteum, peritoneal toileting. I did a peritoneal toileting, praying God on progesterone, tons and tons of progesterone as usual. With AG progesterone can rescue. This is a psychological. Also, I am part of the same gynecologist as you people. Oral, parenteral, vaginal, everything we did it, and praying God. But follow-up scans after 2 weeks. I did it. I find the gestational sac with normal yolk sac. Small fetal node, cardiac activity not detected, but rising trend of beta hCG. So initially I had suspected one thing, suspicion endometrial thickness is 14 millimeter, that it could be probable intrauterine pregnancy. But the right adnexal mass with vascularity and this minimal fluid, that has confused me. So that I did a diagnostic lab. I didn't find anything. So again, I thought it could be intrauterine, probable intrauterine. So follow up, say that rising beta hCG and small fetal node. Repeat scan after 2 weeks, I did it. Single intrauterine live fetus of 7.6 weeks, normal sac, live fetus. I was so happy, patient was so happy. Pregnancy continued, spontaneous vaginal delivery, and a female baby. So this is one example where a pitfalls in diagnosis and how a conjugative, a very early intrauterine pregnancy is missed, and with the ectopic pregnancy. So the message here, early intrauterine pregnancy with corpus luteum with pain abdomen mimics feature of ectopic pregnancy. Think of it. Need for follow-up scan, beta hCG, and expectant treatment for probable early, very early intrauterine pregnancy. Persistence of symptoms or aggravation of pain, sonographic evidence of significant fluid or blood in peritoneal cavity is an indication of diagnostic and therapeutic lab for that. And don't use the uterine manipulator in those cases where you have suspected probable intrauterine pregnancy. Uterine manipulators are to be avoided for that. And continuation of intrauterine pregnancy and viability is possible. Situation 2. This is 28 years conceived following infertility. I've done a diagnostic therapeutic histolab and hysteroscopic cannulation blockage. Overdue 14 days with spotting PV, UPT positive, sonography, empty uterine cavity, endometrial thickness 8 millimeter, gestational sac, left adnexal region. No fetal node, but gestational sac could be demonstrated. Beta hCG was 1500. Repeat beta hCG after 48 hours, it rose 1600. Sonography again, cavity empty. Gestational sac visualized, left adnexal region, no fetal node, and plan for medical management. Patient is very anxious and she didn't opt for a diagnostic lab. Patient opted for a medical management. Injection methotrexate 50 milligram I am given. Refused for hospitalization, but counsel done. Counseling done for immediate hospitalization and warning symptomatology. If there is any problem, you immediately present it. Advice for review beta hCG and sonography after 1 week. Now presented after 3 days with syncopal attack, acute pain abdomen. On examination, clinical, I find tachycardia, blood pressure falling 70/40, sweating, abdominal distension with free fluid in the blood, and plan for immediate surgery. Only sonography revealed massive hemoperic collection. No mass could be seen, nothing else could be seen. And this is a picture of that. There was a massive collection. There are blood clots in the pelvis, but there are plenty of free blood all around upper abdomen, liver, and everything. So immediately before this clot, which you see now, before this clot, I could remove 2 units of blood for auto transfusion. So immediately I removed, through the laparoscopy, I put it and then removed 2 units of blood liquid blood before entering to the pelvis. And then I entered the pelvis and found out the clots and all that. And I could get 2 units of blood, which immediately I transfused because the patient blood pressure was 670 by 50. And therefore, this auto transfusion, 2 units immediately given intraoperatively. And now I find that the left tube, can you see the left tube, the ampullary portion, there is a rupture and active bleeding. So this is not demonstrable by sonography. This small, so this is a proximal ampulo-isthmic pregnancy, proximal ampulla and isthmic pregnancy. There is a rupture in the antemesenteric border, active bleeding is there, but no definite mass is there. And after thorough the removal of the blood and blood clots from the pelvis and abdomen, and we did the salpingectomy. First, arrest the bleeding as far as possible. For visualization, whatever is possible, you just aspirate. For auto transfusion, whatever is there, you just do it. And then immediately the salpingectomy is being done. Left salpingectomy is being done. Bleeding is arrested, and that is possible by using, you can view varieties of methods that are available. This is a Martin's bipolar vessel sealer, and along with the cutter, mechanical cutter, which so automatically it cuts, or else you can use the conventional bipolar and then with the seizure you can cut it. But here there is no chance that you do this salpingotomy. You can do a segmental resection here, but salpingotomy is not at all possible here. So this is important to save the life of the patient, and this is a failure of medical management where on follow-up we find that it has ruptured for that. And you must be very, very sure about the coagulation, about the bleeding, and then a thorough lavage, removal of the blood and blood clot is important for that. Now I'm safe that yes, bleeding is controlled. I've got 2 units of blood for auto transfusion, and then I think I'm very now stable that the patient blood pressure is maintained. The thorough ligation, thorough irrigation of the abdominal cavity, and if at all there is a bleeding, you can use the bipolar and seal it for that. So the thorough coagulation is important, and a good hemostasis is important for that. So this is a massive hematoperitoneum blood collector for auto transfusion. Left tubal ampullary rupture with active bleeding, salpingectomy done, blood and blood clots removed, peritoneal toileting done, right tube and ovary healthy, tissue removed through right lateral port, uneventful post-op recovery. And remember, all these cases you send the patient for histopathology, specimen for histopathology. For medical legal purpose, also it's important, the confirmed tubal gestation. And the patient had a spontaneous conception after 1 year, and a live fetus, intrauterine live fetus was demonstrated, 8.4 weeks, regular ANC, cesarean delivery, male baby 3.2 kg. So what is the message? Medical method of treatment with methotrexate, accepted treatment modality of ectopic pregnancy with the selected criteria. And these are the definitive criteria: clinical, sonographic, and biochemical criteria. Mass less than 3.5 centimeter, sonography, and a relatively asymptomatic, a little pain, not much of this, and biochemical, the level of beta ICG must be low. Compliant patient under supervision and constant follow-up is necessary for that. Immediate surgery saves life. Immediately she presented and the surgical intervention was done. Laparoscopy is not a contraindication in hemodynamically unstable patient nowadays. If this fit for anesthesia, then is fit for surgery for that. And yesterday's contraindications are today's indication. And of course, auto transfusion, a practical method whenever possible, you do it. My experience of auto transfusion is with 13 cases, 5 with laparotomy and 8 with laparoscopy. 1 to 4 units I have been able to do that. And the only thing is that it is 100% cross-matched auto transfusion and easily available immediately for that. And the methods are not very difficult procedure. Initially, when we started the procedure, we used to filter it with the gauze and giving that. Now, the blood transfusion set is available with the filter, and we after collection, we through the filter you collect the blood and then transfuse it. There is not a problem. And the only thing is that a different set of people should be there for that purpose. The same person cannot do the surgery or cannot this. He will help, and these persons will collect it and give it for them. So immediate control of active bleeding is the vital step, and salpingectomy is a preferable procedure for that. Future intrauterine pregnancy is possible with the healthy other tube. Situation 3, 30 years, gravida 3, para 1, abortion 1, conceived following secondary in 42 years. Sonography, uterine cavity empty, endometrial thickness is 10 millimeter, but there is a single gestational sac with live fetus, 7.6 weeks in the left adnexal region. Remember this. Repeat sonography confirmed the same findings. A good man and machine is important, as I have already told, and plan for lap surgery. When we find that it's a left ampullary pregnancy, salpingectomy, peritoneal toileting for that. And this is a picture for that. Remember how accurately. This is not a rupture, and it is a live pregnancy, and minimal collection is there. Had we left it for some days, it would have gone for rupture for that. And it is in a process of undergoing rupture because we find little blood in the peritoneal cavity for that. And how, with the accuracy of the ultrasound and machine, with the demonstration of the live fetus, I think you are 100% confirmed that it is a ectopic pregnancy for that when the cavity is empty for that. And here what we do again, salpingectomy. In live fetus, usually salpingotomy will give rise to torrential bleeding, and arrest of the bleeding is not possible to the edges of the tube, and therefore a salpingectomy as usual with the same procedure. This is with another methods like a conventional bipolar, and then using the scissor and removing the tube, salpingectomy. So the left tube is being removed, and you can see go slow because the patient is stable. The patient is not there is no internal bleeding, and it's a very good case for bed there. But you see a live fetus. Then I saw that this is a case on retrieval of the second port with the 10 port. The product of conception along with the tube is retrieved, and you see find a clean cut, very good embryo is being found. It looks very nice, but very pathetic for that also. Through the laparoscopy, it looks very nice to see the fetus, but it's a live fetus, and because it's a, and believe me, the patient was asking me before that, sir, can you transfer the fetus from the tube to the uterus? I told this is the fantasy, maybe that in future it could happen. The transposition of the extrauterine fetus to intrauterine position for that. And that is possible, that is not possible nowadays. So the passage in future it could be possible. Resort to early diagnosis by sonography is possible. Man and machine is important. Empty uterine cavity is important finding. Medical methods are contraindicated here, and laparoscopy is the mainstay. And patients thought of fantasy, transposition of live fetus from tube to the uterus could be possible in future by my grand students and students. Maybe I will just listen and be happy that this is possible. I was not able to transport the fetus from the tube to the uterus. You could do it. You could achieve the success for that. Situation 4. Again, primary gravida, conceived following IVF at 6th week, beta HCG 4500, asymptomatic, single gestational sac, fetal node not demonstrated. Repeat sonography after 10 days, uterine cavity, pseudo gestational sac with fluid, single live fetus, 7.6 weeks, right adnexal region. Again, bad luck. Pregnancy following IVF, but it's a tubal pregnancy. Right ampullary pregnancy, minimal peritoneal collection, left tube and ovary healthy. Again, salpingectomy done for that. See the picture. This is a case where patient was conceived following the IVF treatment. Now you can see the right tube, and it's an unruptured pregnancy. And this is particularly more important. The other type, tube and ovary, is normal, and this is particularly because So this is particularly possible. This is particularly possible because IVF pregnancy, you diagnose early, resort to sonography is important for that. And that is an unruptured pregnancy, which is seen here in the right side for that. Left tube and ovary is normal, but I think these are the cases not amenable for the conservative surgery like salpingotomy, and salpingectomy is the preferred method, and we did the salpingectomy method. This is again a different equipment, a shear, and this is a shear where the current cuts it also. So the tip cuts, and this is an instrument which I'm using with Alan Indian equipment, and that Alan and PB are the two companies who manufacture this shear, where the seizure is not required, you coagulate it, and the tip cuts it for that, and that dissection method is there. So this is a very good equipment, and I did this. The whole of the tube I removed, and then I did a salpingotomy to see whether what is inside, and now inside breech delivery is there. Now you can see the fetus, beautiful fetus, and then, but unfortunately this fetus is not going to survive for that. So this is unlucky patient conceived following IVF but landed in this tubal pregnancy. So the message is tubal pregnancy in ART is not uncommon, it's common, because during IVF there is a chance of tubal pregnancy, there is a chance of heterotopic pregnancy also, which I will show. Concern for the physician as well as for the patient. IVF pregnancy possible by technology, but to have a baby is destiny for that. So therefore, this is one of the unlucky patient, and I am one of the unlucky gynecologists. What next? It is $1 million question. The patient asked me, and I had to very difficult to reply. Just counseling and consoling that. Situation 5. 27 years. Again, conceived following primary infertility, IUI this time. 20 days overdue, pain abdomen with spotting PV 2 days, beta HCG 5000, so high. Sonography, twin gestational sac, one inside uterine cavity with fetal node and demonstrable cardiac activity. Intrauterine live fetus, another in right adnexal region, fetal node seen without cardiac activity, but moderate peritoneal collection and blood. And diagnosis here is heterotopic pregnancy with live intrauterine pregnancy. And therefore, because there is a bleeding, active bleeding there, and I did this. This is a sonographic picture. You can find that out. That intrauterine live fetus is demonstrable, but extrauterine, the cardiac activity is not seen. And there is a plenty of fluids or suggestive of blood inside the peritoneal cavity. And patient is having pain abdomen. So it's a diagnostic, clear-cut diagnosis of heterotopic pregnancy. So with this sonography, we diagnose that it's a case of heterotopic pregnancy and then plan for laparoscopy. So we counsel the patient, normally you counsel the patient that we try to conjure this uterus, the uterine pregnancy. Now you see in laparoscopy, there's a blood and blood clots which is there. And therefore, we find just do a good lavage and remove the clots. It's very difficult in laparoscopy when there is a more of fluid, frank blood, it is easier. Within no time you can clear it. But a clots particularly, it's very difficult. You can put a 5 mm telescope also, a 5 mm suction, a 10 mm suction cannula, but usually with the 5 mm suction cannula, with the good suction machine, it will done the purpose for that. And this was a case of pelvic endometriosis also. I've treated, laparoscopic surgery has been done earlier, followed by IUI. You find that the uterus is enlarged. There is a little adhesions, POD, there is an adhesions. And remember, in this particular patient, absolutely, when you find that the intrauterine live pregnancies, there is automatically, it is implied that you don't put a uterine manipulator, minimal handling of the uterus to be done for that. So minimal handling of the uterus, and then we did this salpingectomy, right? Salpingectomy, we did this, removed the tube, and praying God that the intrauterine pregnancy should continue for that. And therefore, this particular case, the rupture of the tubal pregnancy with the healthy pregnancy intrauterine, with a moderate amount of hemoperitoneum needs a laparoscopic surgery. And after the surgery, I think the total postoperative period was uneventful. And again, tons and tons of the progesterones has to be given for that. And this is a procedure where you see for that. So laparoscopy, moderate hemoperitoneum, uterus enlarged, congested, minimal pelvic adhesion, right tube dilated at ampullary region, salpingectomy, right done, fetus along with the right tube removed through the right lateral port, peritoneal toileting done. On progesterone, follow-up scan, intrauterine live fetus 9.4 weeks. And regular ANC, elective CS at 38 weeks, term male baby of 3 kg. So the message here, heterotopic pregnancy not uncommon nowadays. And IUI is a predisposing factor. Sonographic diagnosis is predictable. Laparoscopic procedure is the mainstay. And no handling of uterus. This is important. Minimal handling of the uterus is important. Continuation of intrauterine pregnancy is feasible for that. Again, another case, just about a couple of 4 days back, this was a case. That's why I thought that it will be presented now. 4 days back, I saw this patient. 25 years primigravida, married 8 months, spontaneous conception, missed period 8 weeks, UPT positive, presented with acute pain abdomen with abdominal distension and pallor, signs of peripheral circulatory failure, pulse rate was 140 per minute, BP was 70/40, cold clammy skin, sonography reveals twin fetuses, one intrauterine at 8.6 weeks with absent cardiac activity, and another pregnancy in the right adnexal region, 8.4 weeks, fetal node demonstrated with absent cardiac activity, both IUFD. Massive hemoperitoneum, hemoglobin was 6 gram percent, and although there is no chance to conjure the babies, fetuses, because of both are IUFD, planned for immediate lapses. There is no risk factor. It is not conceiving after IUI or IVF. It is a spontaneous conception, young girl of 25 years. Diagnosis heterotopic pregnancy with IUFD at 8.4 to 8.6 with peripheral circulatory failure. See this picture. This is a intrauterine, one of the intrauterine. Both the sac and fetus are visible, but absent cardiac activity in either. And, and lots of fluids are suggestive of blood in the peritoneal cavity and corroborating with the peripheral circulatory failure for that. So this is another case where you find previous case, I could have a baby because it was a living baby, but this is heterotopic pregnancy, spontaneous conception, but unfortunately this is. And see the massive blood in the peritoneal cavity, and that's why the blood pressure was less. And with the same thing again with the auto transfusion, I did the auto transfusion. I sent the requisition for 2 units of blood, and I could get 2 units of blood in the auto transfusion also and gave it. And see, remember, as soon as the visibility is not there, as you just don't spend much of time. The technique is that don't spend much of time in complete suctioning of the contents. As far as the visibility is there, you just do the suction till the visibility is there. Once the visibility is there, finish the bleeding part, arrest the bleeding, and you could find the right tube and bleeding ampulla. The ampullary portion, there is a rupture, the placental tissue are being seen, and then immediately you arrest the bleeding first. Then the rest of the part, suction, removal of the clots and other thing, you do it for that. So that is important. Massive bleeding, you just do the suction evacuation till you find the anatomy, until you find the diagnosis that this right tube, there is a rupture, and then immediately arrest the bleeding. Now, this is the paramount important. This is the tips and tricks of all surgery. May it be laparoscopy, may it be laparotomy, whatever it may be. Then after that, after removal of the tube, then you just do a thorough lavage, take your own time and thorough lavage, because it's a patient which under peripheral circulatory failure, under anesthesia, we're doing a lap surgery, abdomen is distended, all the risk factors are there. And therefore, but one thing is that, again, I can say that in hemodynamically unstable patient, if you're careful, if you've done a good job, you can finish it within no time, provided the patient is withstanding the anesthesia. I say that the patient will be withstanding the surgery for that also. And this is a damaged tube, no question of conservation of the tube in this particular case for that. So the message, heterotopic pregnancy possible with conception. And here I did one thing again. Again, I did this particular case. After that, I did the uterine suction and curettage, plenty tissue, the POC came because I know that it's an intrauterine pregnancy. And here you can do a manipulator. This is a case where manipulator can be used. Plenty of tissue and POC removed and sent for HP study. 2 units of blood transfused and then vital stable. And heterotopic pregnancy possible with spontaneous conception, cause difficult to explain here. High resolution sonography, an invaluable diagnostic aid. Immediate surgical intervention saves life. Both IUFD, a bad luck for the patient, but life is saved. Destiny and technology is responsible. So lap surgery is not an absolute contraindication in hemodynamically unstable patient in current scenario for that. Situation 7. This is a case 30. This is a case 30 years, para 1, abortion 1, overdue 10 days, acute pain lower abdomen on right side. Serum beta ICG 1200, sonography uterus normal in contour dimension, endometrial thickness 7 millimeter, no adnexal mass, but evidence of a little pelvic hematocele with minimal peritoneal collection. So I did a diagnostic and therapeutic lab. Here you can find this particular picture for that. There's a minimal pelvic collection, peritoneal collection, but you can see the ischemic pregnancy. Can you see the ischemic pregnancy here? It is not ruptured. This is a very dangerous situation. Ischemic pregnancy, when ruptures, immediately go for acute peripheral circulatory failure. And because the vascularity is very close. But therefore, the diagnosis, early diagnosis is important, particularly in ischemic. And that ruptures early. And once it ruptures, it's very difficult to save. And here, I planned for segmental resection of the tube. Instead of doing a whole salpingectomy, I did this segmental resection of the tube. And you can see the segmental resection. It's not that difficult for that. And this is mainly, if you think of tubal, number one, it gives a psychological satisfaction to the patient. Second, it gives a chance that rarely we can do the implantation, cornual implantation in subsequent surgery. Microsurgery can help in this particular case because the length of the tube is more than 5 centimeters for that. So here a good hemostasis is important. You do a good coagulation. The bipolar must be very good, and this. So this many cases of ischemic pregnancy are seen with acute rupture with the peripheral circulatory failure. But this is unruptured ischemic pregnancy with just minimal collection, so that diagnosis early, and we can do the diagnostic and therapeutic lab at the same particular sitting for that. And you send the specimen for histopathologic examination, and good hemostasis should be maintained with the bipolar is enough for that. And that serves the purpose of the laparoscopic surgery for ischemic pregnancy. So ischemic pregnancy is also rarer. Commonest is ampullary. Then the ischemic is about 11 to 12%. Then fimbrial pregnancy. Then we come to the interstitial pregnancy, and the other pregnancy are very, very rare. Cervical pregnancy, ovarian pregnancy, CS scar pregnancy, and other rare pregnancies could be seen. Now the hemostasis is complete. We have not damaged any anything on the myometrium, and uterus. In this case, we find a subserous myoma. But subserous myoma, whether it is a cause of ischemic pregnancy, very difficult to explain in this particular case for that. But we must find out and document this particular finding for subsequent fertility promoting thing and all that. So this is a laparoscopic finding, and message: ischemic pregnancy is not is uncommon. Next to common is ampullary. Early rupture with massive hemorrhage is very often seen. Salpingectomy or segmental resection is the treatment of choice depending on the tubal status. The tube is normal. Length I can get it more than 5 centimeters if I leave it, and therefore I prefer to do a segmental resection. So segmental resection will give a psychological reassurance for the patient and future chance of tubal microsurgery and reconstruction from clinician's viewpoint for that. Situation 8 is again a very interesting case. very rare case. 28 years, para 1, missed period 8 weeks, bleeding PV 2 days, UPT positive, sonography elsewhere, evidence of interstitial pregnancy. I was surprised how the sonologist has diagnosed interstitial pregnancy, right? No collection, serum beta aci 3.500. So therefore, to reconfirm, I did a repeat scan, and repeat scan confirmed interstitial pregnancy with high resolution sonography and an expert characteristic interstitial line sign. That's important. A hypoechoic line can be drawn out from the endometrial cavity to the gestational sac, to the ectopic gestational sac, and that's very important interstitial line sign. So I did a laparoscopic examination. I find the typical interstitial pregnancy I could find on the right side. You see, uterus is enlarged, asymmetric, and the cornu there is a bulge. It is a congested, and therefore we find that this is an interstitial pregnancy, corroborating with the sonographic finding. The laparoscopy has corroborated this, and to reconfirm, I did a hysteroscopy on the same sitting. You see the hysteroscopic finding now. That the hysteroscopic finding, the ostia is at a higher level than the other normal ostium. Then I decided to do this. There are two options, either a cornostomy or a cornual resection. I decided here for a cornual resection. So before that, I have infused vasopressin for the bleeding. After the vasopressin infusion, very carefully, you again do the segmental resection from the proximal ampulla. You start it and you excise it completely. It's more difficult than interstitial pregnancy because you have to excise the whole of that. Some of the muscles, myometrium can be incorporated, and you must remove that myometrium also, because the cornual resection, myometrium has to be removed for that. Otherwise, it's not possible. Otherwise, it's not possible to remove whole of the pregnancy sac for that. And this is how you do the procedure of cornual resection. And this vasopressin is absolutely helpful for us. Otherwise, a severe bleeding would have been there, and the field would have been messy for that. So this is a procedure which you do it. Another procedure, you can do a cornuostomy. You just give an incision, like salpingotomy. You just give a linear incision, and again after the vasopressin, then remove the product of conception, and then you find the coagulation and keep the thin the myometrium. The myometrium is absolutely thin there when you remove everything for that. So the procedure is all same, because this procedure is much better than cornual resection, is much better than cornuostomy, but many people do a cornuostomy also. But mainly remember, after this, unlike the interstitial pregnancy, the after removal it, there is no bleeding. There is no bleeding. But even if there is no bleeding and you can arrest the bleeding with the bipolar, the muscular integrity, for the muscular integrity for future pregnancy, you have to do a suturing. And therefore, suturing is mandatory here in a case of interstitial pregnancy after excision, after cornual excision for that. And therefore, you see there is no bleeding, but there is a risk of rupture and the subsequent pregnancy, because this part is weaker and the muscle are there for that. And suturing also has become little difficult because the pregnant state, uterus, and the suturing will tear off the muscle. So a thicker bite is important. So now I'm using this barred suture for suturing this, and a thicker bite. Remember, otherwise it will tear off. And once the tear off is there, I think a lot of bleeding will be there, and it will cause a lot of problem for that. So the barb suture, or otherwise you can use the conventional vicryl also, but barb suture is very, very convenient for suturing. And see, you have to close the myometrium, and this is how you do a suturing. The round ligament is brought and closer to that to complete the procedure of suturing. And it gives two main purpose. Mainly, hemostasis is one. Second important is main thing is the muscle integrity, the myometrial integrity in the subsequent pregnancy, if at all. The chances of rupture is least if you suture it for that. And barb suture have shown equally good results than the as vicryl, because it's better that a position will be much more better, and the things are completed for that. So this is a very important case. I have a couple of cases of interstitial pregnancy done with the same procedure for that. And then you remove the tissue and send it for the histopathological examination for that. So histoscopy done, cavity asymmetrical, right ostal lesion seen, lap corneal resection done, repaired with barbed suture, hemostasis maintained, tissue sent for HP study, confirmed tubal gestation, uneventful post-op period. So the message is interstitial pregnancy very uncommon, rare, diagnostic accuracy by high resolution sonography and expertise. Cornwall pregnancy and interstitial pregnancy are interchangeable terminology, synonymous terminology. There is another term called angular pregnancy and all that. So angular pregnancy is the pregnancy in the Mullerian anomaly of rudimentary horn of the pregnancy is the angular pregnancy, but Cornwall and interstitial are synonymous terminology which is being employed for that. LAP approach with skilled endoscopic surgeon is preferred. And I feel now that the nowadays the next generation of gynecologists, my students and grand students, will teach me laparoscopic surgery. They're more skilled than me, than our previous generation for that. They will do a much better job for that. So cornostomy and corneal dissection modalities of surgical intervention. Suturing strengthen the myometrium of cornu for preventing rupture during future pregnancy. And another thing in cornostomy, even if you do a cornostomy, you have to suture it to strengthen the myometrium. And second important, post-operative methotrexate, you have to give it because you are not sure whether whole topoplastic tissues have been removed or something is left behind. So that's why I prefer corneal resection better than cornostomy for that. Situation 9. This is a 30 years para 2 overdue 20 days. UPT positive, acute pain abdomen, right left fossa with bleeding PB 2 days. Serum beta CG 1600, sonography uterus normal in contour and dimension, endometrial thickness 10 millimeter, minimal collection of fluid in cul-de-sac. But there is a right adnexal complex mass of 6 centimeter, 5 centimeter, 4 centimeter. Patient is having pain abdomen and it is not relieved with the drugs, medications, beta HCG positive, and there is a mass. So the diagnosis is 100% that it's a the ectopic pregnancy. Uterine cavity is empty, and this is no doubt that there is a ectopic pregnancy. So I decided for the diagnostic and therapeutic. You see, here there is a minimal collection. The small amount of blood is being collected. Uterus is retroplaced, retroverted, and I couldn't find. Now I could find the left ovary and the tube, but there is a right tube mass on ultrasound. Let us see what is coming out of that right tube mass. We thought of the right tubal pregnancy, but see, the right tube is absolutely normal. Right tube is absolutely normal, and the ovary is enlarged, fixed to the ovarian fossa. On lifting, I find that yes, right tube is absolutely normal. The contralateral tube and ovary is normal. There's a minimal collection only, and you just retract it and find it out. Do a salpingo-ovariolysis on the right side and just lift it because there is a small amount of adhesions there. There you can see that will appear as a tube ovarian mass, and there's a complex mass and a vascular mass also. The color Doppler show the vascularity and all that. Now you can find that the whole of the ovary is found. Now I'm confirmed that this is an ovarian pregnancy. It could be confused with corpus luteum, but corpus luteum, the beta HCG will not be positive. And of course, this particular case, I've sent the tissue and confirmed that there is an ovarian pregnancy for that pregnancy topoplastic tissue along with the ovarian tissue for that. So see, the ovary, I've dissected this particular ectopic pregnancy from the ovary and did at least a partial oophorectomy also. The ovarian, see the product of conception completely detachable from the ovary, and I sent the specimen, and here I removed it. This side is completely attached adherent to the ovary. It's not possible to remove, so I have to do a resection, and preceding that I have to do the bipolar coagulation. Otherwise, the bleeding will be much more. It's a vascular, and see, these are all rare cases. Ovarian pregnancy cannot be diagnosed. It is a retrospective diagnosis. Ovarian pregnancy cannot be diagnosed before surgery for that. because the Spiegelberg criteria is there, that unless you see that the pregnancy occupies the position of the ovary, that's one. The ipsilateral tube is absolutely normal. That is number two. And the pregnancy with the ovary is attached to the ovarian ligament, by the ovarian ligament to the uterus, and histopathological confirmation of ectopic pregnancy along with the ovarian tissue. So that's why I did the job. Very rarely I can find out. And this laparoscopy can finally diagnose that this is a case of ovarian pregnancy. Otherwise, it will come as a majority of the cases of this type of findings come as the chronic ectopic, where the tube is involved for that. Here you can find the tube is absolutely normal and is completely arising from the ovary. Now, healthy ovarian tissue, I could preserve it, and the rest, the POC, and along with the removal of the POC and small ovarian remnants, I just coagulated. The suturing is not necessary because you just coagulate, do a good homeostasis, send the specimen for the histopathological examination, and of course, a serial beta ECG, you must do it. And if the serial beta ECG is not falling, then there is a place for the postoperative methotrexate. Otherwise, postoperative methotrexate is not indicated in this type of ovarian pregnancy for that. If there is a persistent trophoblastic disease evidenced by the serial beta ECG rising or not coming down, I think these are the cases where methotrexate is to be given for that. So this is a very, again, a rare case which I find it in one. So the message, yeah, these are the findings. Right ovary enlarged with the fleshy mass on surface of the ovary, resection of the fleshy mass from the ovary done, healthy ovarian tissue preserved, fulguration of the ooging done, tissue removed and sent for HP study. This is mandatory for that. And HP confirmed ovarian pregnancy, and of course the intraoperative finding also confirmed ovarian, satisfying the Spiegelberg criteria, age-old criteria for that. So ovarian pregnancy very rare, criteria to be fulfilling for the diagnosis: ipsilateral tube normal, mass incorporated to the ovary attached to uterus by ovarian ligament, HP incorporation of ovarian tissue with the POC, partial oophorectomy or oophorectomy. If it would have been the pregnancy is not warranted, future fertility is not warranted, patient is elderly, I would have done a oophorectomy, complete oophorectomy. But in exceptional cases where conservation of the ovary is not possible, you can do also an oophorectomy for that. So HP confirmation is absolutely vital, cause we do not know some individuals why ovarian pregnancy occurs. This is another case, 32 years, gravida 2, abortion 1, history of tubal pregnancy left. There is a history of tubal pregnancy left, and laparotomy was done, and salpingectomy. Laparotomy was done elsewhere, salpingectomy 1 year ago. And conceived following ovulation induction, overdue 10 days with bleeding PV and pain abdomen. Serum beta ECG 900, sonography, uterus normal in contour and dimension. Endometrial thickness is 10 millimeter, moderate collection of fluid and blood, both ovaries normal, no adnexal mass, but persisting pain. The repeat beta ECG after 48 hours, not very much increased, but 1000, with sonographic evidence of empty uterine cavity again, with minimal fluid, blood in the peritoneal cavity. And we diagnosed that recurrent tubal pregnancy. Patient was counseled. Patient was very much anxious and depressed. Once I had a tubal pregnancy, one tube is damaged, left tube is damaged. Now the right tube, we will remove it. What I will do for that? She was very much depressed and anxious, but I planned for diagnostic and therapeutic laparoscopy. I was also very much apprehensive, and this is a case on laparoscopy. Due to the previous previous laparotomy, see the extensive abdominal pelvic adhesion. The extensive abdominal pelvic adhesion, we have to clear it first because nothing was visible for that, excepting small amount of collection is there, not the acute hemoperitoneum. There is a little mild hemoperitoneum, little collection is there. And again, with the sear, I'm just dissecting and separating the momentum. There is an extensive adhesion because of the previous laparotomy. So unless I just remove it, I can't see anything for that. The second port is also very difficult to put it. With the two ports, I do the surgery always, and This is important. So after the adesolysis is being done, the second port I think is better negotiated with that, and then we can see what is in the pelvis. Till that time, I'm not able to see what is there in the pelvis for that. So for clarity, this dissection is necessary for that. And then we can see the uterus and focusing attention on the right tube more, because the left tube is already removed, and there is a collection in the pelvis. There is a minimal collection in the pelvis, little hemoperitoneum, and the collection in the pelvic. But in this is the left side. This is the left side. There is a bleeding coming out. I was little happy. I was expecting the right side. Right to tube and over is absolutely normal. Can you see the light right over and tube, which I was expecting that the recurrent ectopic is there in the right tube. I had to sacrifice both the tubes. Now the peculiarly God has saved us. And God is very kind enough that there is active bleeding, there is a nomental adhesion to the left cornu, and left cornu there is a bleeding. Then I was very happy that the other right tube was normal, and on adhesolysis, when the omentum is being removed, I find the tubal stump. The tubal stump, left tubal stump, which was previously the salpingectomy has been done. The tubal stump, there is an ectopic pregnancy, because the beta HCG is also corroborative with that. With this laparoscopy finding, I could find the product of conception here, and this is a stump ectopic, which is very rare but seen. So all varieties, as my hairs is growing, I could be able to see all varieties of ectopic which I could present before you, and therefore I'm very happy that the I could show the surgical skill transfer and the E-Gurukul program for you. All of you must have seen all varieties of CA, much more and number maybe more than me, but I want to convey this by putting all the see at that point of time the bleeders are there acute, because in the isthmus part, in the isthmic part, there is a oozing, and you see that this oozing can be controlled with the coagulation with that. So this is an oozing from the isthmus, but fortunately this is a stump ectopic pregnancy, but just with the simple bipolar the bleeding is arrested for that, and that completes the procedure of the surgery, and patient has an uneventful recovery, and he was very happy. The tissue which I obtained, I sent it for histopathological examination. It came out to be trophoblastic tissues. It came out to be compatible with the pregnancy stump ectopic. So after doing a peritoneal lavage, suction and irrigation, and I was very hopeful that the second, the normal the healthy tube and ovary, I couldn't say that it's healthy. Looking is healthy, but I would be very happy if the pregnancy would have been there through that tube for that. And the tissue is sent for the histopathological to confirm it for that. So excision of the tissue, free spill of dye. I again did a dye test for the right femoral, and a free spill of dye has come out for that. Post-operative methotrexate I have given. Post-op to prevent persistent trophoblastic disease. Uneventful post-op period. Patient and doctor both were happy. Right tube, the only savior of the reproduction, which I demonstrated that is healthy, but and God helped. Spontaneous conception after 1 year. Intrauterine pregnancy. Once the pregnancy is positive, she was again apprehensive. Till she insisted that at 6th week you do a scan. But in 6th week also I was interested to do it early, and it is an intrauterine pregnancy demonstrated at 6th week. Then antenatal checkup continuing, and preterm vaginal delivery at 35th week, premature rupture of membrane, and the healthy baby could be delivered for that. So the message, stump ectopic, a rare occasion, diagnostic accuracy by laparoscopy only, hope for subsequent pregnancy, surgery not very difficult or complex. It's a lucky patient, and I am a lucky gynecologist for this patient, and that's why things are really solved for that, and God is great. Situation 11. 28 years, gravida 3, para abortion 2. Previous 2 abortions, overdue 10 days. First conceived following hysteroscopic tubal cannulation. Tubal pregnancy, again tubal pregnancy left. Conservative lap surgery done, salpingotomy done. Laparoscopic salpingotomy done, preserving the tube in the left side 2 years ago. Second, spontaneous conception. presented with acute abdomen, massive hemaperitoneum, lap sulping segmental resection of left tube done 1 year ago. And the same tube where I did this salpingotomy, that is there. Third is spontaneous conception, overdue 10 days, pain in right iliac fossa, right side, UPT positive, serum beta CG 800. Sonography, it was normal in contour dimension, right hematosalpinx, minimal fluid in the pelvic cavity. Again, patient become very much depressed. The third time I find this, and this is a case where the right tube is edematous. You can see the right tube is edematous, small hematosalpinx, and it's a the dilated right corpus luteum can be seen very well, and the left side, the tube and ovary. I think you can see that the tube there is a previous surgery and salpingectomy, the segmental dissection of the tube. Then the distal tube, can you see this distal tube? Initially, I did this salpingotomy. Then the second time, just for psychological satisfaction, I did the segmental dissection, keeping the fimbral end and the distal tube. But I was not expecting that this tube could be functioning for that. And this is a previous surgical methodology. And here I find that the right tube was distended, and I didn't have any option of doing that. Just to see that what is inside, I did a salpingotomy and find out what is there to confirm that this part of the tube is there. So I gave an incision in the antemesenteric border, and just went what is there, just to find out what is there inside and confirm that there is a pregnancy, I think, tissue, uh, mm, and then I send it. So this I went and find out, and this is a linear incision using a cautery, and demonstrating that yes, there could be, unless I find out there is a hematosalpinx on that, there is no definite mass or something like that. But um, I just I could have done a simple salpingectomy and sent for a biopsy, but intraoperatively I wanted to explore what is there inside the tube, what is there inside the tube, whether it's a normal or something else, or POPUL or something other diagnosis than that. So here I find that yes, clearly I find that it's a product of conception, and this product of conception separately I have sent it for histopathology. Can you see this? This is a product conception which came out. I confirmed this, sent it separately to for histopathology, and then I did a salpingectomy. I didn't leave the tube, and did a salpingectomy, removed the tube, and confirmed that it is an ectopic pregnancy. So this is one example of recurrent ectopic pregnancy, and very unfortunate patient. That evidence is prone for ectopic, and very, very unfortunate and all that. So what is the message? So this is a thing which she had an uneventful post-op period, but very depressed for that, and counseling for IVF. I discharged. I said that you need only IVF for that, and recurrent tubal ectopic is not uncommon. Bilateral tubal damage due to PID could be a cause for that. Salpingotomy increases the chance of future tubal pregnancy. Salpingectomy with IVF is the rational answer in this particular case. And now the patient will undergo the IVF, and maybe that it's her lock and my lock could be given contributing for that. This is again a 30 years, primary infertility 8 years, investigated elsewhere, presented with acute pain abdomen, LMP 15 days ago, no history of missed period, fainting attack, examination pallor triple plus, pulse rate, tachycardia, BPA 80/50, abdomen distended, tender, sonography, plenty of fluids and blood in the peritoneal cavity, and plan for immediate surgery, lap approach. And I didn't wait for beta SCG report, but I sent the beta SCG. Beta SCG is sent, awaiting reports, and immediately to save the life, I planned for diagnostic and therapeutic lab. You can see here the whole abdomen is filled with the blood, massive hemaperitoneum in this particular case. Now, as we told that yes, a paracolic goiter and subdiaphragmatic area, the liver surface, and the pelvic peritoneum. Everything is full with blood. The aspiration, suction, suction, and peritoneal toileting was being done, removing the clots. Removing a few clots are there in the peritoneal, in the pelvic cavity, but in the abdomen there is a lot of blood which was there, and at that time I didn't know what is there, but I thought that it's a case of ectopic pregnancy and pending report of beta hCG, because to save the life I did it. Now I find that these are blood clots present in the pelvic cavity, and I thought that there must be some tubal rupture which has given rise to this particular entity, which there is a previous history of infertility predisposes also to the ectopic pregnancy for that. So this, as usual, we find that there is no mass, but lot of blood clots were there in the cul-de-sac. Now I find that there is no mass. The right ovary and tube is normal, and the left ovary and tube is also normal, and uterus is normal, but there is a absolutely full with blood. The left tube and ovary, this is absolutely normal. Left tube and ovary, this left tube and ovary is absolutely normal. There is no bleeding, other thing, and all that, and no mass, no evidence of intraoperative findings suggestive of ectopic pregnancy. I was very much worried about it, but ultimately I could do a peritoneal toileting, and now on this ovary, right ovary, I could find on the surface there is a bleeding point. There is a constant oozing. Can you see that in the right ovary? The corpus luteum was there, and the corpus luteum was oozing, giving rise to this type of bleeding for that. And this is one of the cases where this is confused with the ectopic pregnancy, but again giving rise to acute hemoperitoneum and taking the life. So this is all very important differential diagnosis. I've seen a couple of cases like this also. It's not the only case. I've seen a couple of cases I've seen and managed like this. This I'm presenting laparoscopy picture for that, and you can see clearly the massive amount of bleeding arising out of this small oozing continuously for days together. Can you see that? That the ovarian surface there is a bleeding, and surgery is not very difficult. Just suction and clearance of the blood and peritoneal cavity, blood and blood clots from the peritoneal cavity, and just fulgurate it, just coagulate it. The bleeding point, active bleeding point, you catch hold of the ovary and fulgurate it with the vessel sealer or bipolar, simple bipolar, you fulgurate it, that is enough. This is an area where there is a bleeding, and this is a corpus luteum, most rarely ruptured corpus luteum, and constantly there is a bleeding. I want to demonstrate that, and then the bleeding, little these active bleeders are there from the surface and of the corpus luteum, where you just coagulate it with the bipolar. Bipolar is enough, and surgery is very easy. It's not very difficult procedure. With the bipolar, you just coagulate, and bleeding is arrested for that. You can see the amount of bleeding is there gradually oozing constantly for hours, and that gives rise to extensive hemoperitoneum. Just bipolar coagulation and arrest of bleeding is there, and then you leave it as such, peritoneal toileting. So this is very common pre-differential diagnosis. Now the bleeding is arrested, the patient is absolutely having a post-operative recovery for that. So of course I did the 2 units of blood transfusion is required because the patient was unstable. Then I got the report of serum beta hCG after 4 hours. It came out less than 2. So now I'm confirmed that how sensitive is the beta hCG marker, and this is important. The surgery is necessary, and it's a non-pregnancy state where it is confused with acute tubal rupture. And this message is there. Acute hemoperitoneum common in tubal rupture, but corpus luteum hemorrhage could be a differential diagnosis to be thought of. Diagnostic and therapeutic lap is a rational approach, and laparoscopy in hemodynamically unstable patient, not an absolute contraindication for that. Suction irrigation of blood and blood clots from the peritoneal cavity, including subdiaphragmatic region, paracolic goiters, and coagulation of bleeding points from the surface of the ovary serve the purpose for that. And there is no contraindication for laparoscopy in this particular case. Now, this is a case 26 years, para 1, abortion 1, first spontaneous vaginal delivery, second suction evacuation for 6 weeks, pregnancy elsewhere 1 month ago, bleeding continued. And for that, evacuation done again 5 days ago elsewhere. 2 times evacuation has been done. After second evacuation, developed pain abdomen, not responded to conventional analgesics, hospitalized elsewhere, IV fluids, broad spectrum antibiotics, analgesics, but persisting pain was there and sonographic evidence of complex pelvic mass in POD and right adnexa. And that patient was referred to me with a diagnosis of pelvic hematoma, perforation of uterus with sepsis. On examination, I found moderate degree of pallor, tender lump, for abdomen palpable, and PV uterus form, restricted mobility, POD full tender, ill-defined tender lump in the right fornix, hemoglobin 7.5 gram, TLC 11,800, serum beta HCG is again 550. So she has underwent suction evacuation 1.5 months back, and initial, and again after 10 days, second evacuation has been done. But still, beta HCG is 550. Sonography, right adnex and POD, complex mass, uterus normal in confluent dimension. So my differential diagnosis here could be, apart from perforation out of suction, it could be a chronic ectopic. Perforation could be there, could not be there, but it's a chronic ectopic was in my mind for that. And when I put a telescope, I find that there is an extensive adhesion of the pelvis with the omentum, and this was blood and blood clots in the right adnexal region, and I have to clear it. And these are old clots which is there appearing as a pelvic hematoma following the suction evacuation. And this is a case where now I find I could see the right tube distended, right tube distended, and everything was covered with the blood and blood clots, and clearance becomes very, very difficult. The uterus was adherent, there was a frozen pelvis, nothing was visualized. But these type of adhesions could be very easily tackled and separated. Now you could find the TO mass, right TO mass, and the right tube was swollen and edematous, and again a good dissection is necessary. The uterus was also adherent anteriorly. The left ovarian tube, this is the left ovarian tube which was being released, and it was normal. It was it was just adherent lightly with the ovarian fossa on the left side, but right ovarian tube mass you could find them. And tube is more distended, and the tubal pregnancy could be very, very seen on the ampullary part. You can see the tubes and the tubal ampullary pregnancy for that. And now I find that the ovary is normal. It's not a tube mass. I could separate the ovary from the tube, and then did a salpingectomy. Right salpingectomy, I did it. I kept the ovary intact, and this is a chronic ectopic for months, confused with the. And this is a case where I always say that when you do a suction evacuation for termination of the pregnancy, you see, you always see whether the product is coming through the plastic cannula or not. And plastic cannula is much better than metal cannula nowadays. I think everybody applies the Carmen's cannula, and you must see if there is no product from the in the cannula. I think you are wrong in not going to the proper uterine cavity, or you are seeing another ectopic pregnancy. So these are the cases you must be very vigilant and all that. And good amount of dissection and clearance, and POD is well formed now. Everything now you can find out that the dissection is absolutely clear. We could see what is there because absolutely everything was pasted, and I didn't find any uterine rent. So the uterine rent was not found. It is a chronic ectopic, and a persistent period for 1.5 months has given rise to this type of adhesion and all that, and pain and all that. So this is the tissue is sent for histopathology, confirmed tubal gestation for that. And the message, such cases are not uncommon. Suspicion of ectopic during evacuation should be there, as I have already told. Think of ectopic prior to second evacuation. If it's a persistent bleeding, second, third evacuation, I've seen number of cases. Think of ectopic. Serum beta HCG, do a serum beta HCG. It is sensitive even 3 months after the initial pregnancy. In a chronic ectopic, it is so sensitive. It may be low, but if it's positive, you think of ectopic and treat accordingly for that. Meticulous surgical skill is essential to prevent complications. Now, situation 14. 25 years bleeding PV and pain abdomen since LMP for last 10 days. There was no history of missed period, not responding to tonexamic and progesterone. It's the bleeding for the last 10 days. Since last menstrual period, she was bleeding. Sonography evidence of small adnexal mass with moderate hemoperitoneum, uterus normal in contour and dimension, empty sac, but beta HCG is 1500. And therefore, it is a very, very strong biochemical marker, then a plan for diagnostic and therapeutic lab. Here, when I put it, the long back, it's an old video about 15 years back. That time HD camera was not available with the normal camera. See, that's why the quality of the video is inferior to the previous quality. And here we can find that the hemoperitoneum is not very gross. There is a minimal fluid inside, a small amount of blood collection inside, and you do suggest the uterine manipulator is being done, and you can see the uterine manipulator has been given, and you can find the uterus to be normal, little enlarged for that, and then see the adnexa. There is a small amount of bleeding. We are giving the 2 ports, and the 2 ports with the 5 mm telescope we are using in all cases. We are not using the 10 mm also. For retrieval, we can use the 10 mm. That's all right. And uh, here you can see the tube and ovary. What is the finding for that? Left side, there is a mass. There is a suspicious mass on sonography, and right there is minimal. There is hardly, there is an absolutely small amount of fluid. But here you find the left tube like a hematosalpinx. Leftover is normal. There is no much of adhesions in there, and the left tube, the whole of the ampulla is dilated, and you can see the clearly the picture typical of ampullary pregnancy and a tubal mole. This is the tube is not ruptured. There is no adhesion. The other side left, the right side tube and ovary is normal. So here, this particular case is a tubal mole classically, and this is particularly I've decided this particular case as a conservative methods of doing a salpingotomy, linear salpingotomy. I've decided and started the procedure of linear salpingotomy. See how this linear salpingotomy is being done. You have to either give a vasopressin also for arrest of bleeding. That is also can be given, and you can cut it with the scissor or with the power source with the monopolar cutting. You can give an incision on the anti-mesenteric border of the tube, and then go through the enter the cavity and remove the POC. POC can be removed by just suction irrigation. You put an irrigation, forceful irrigation, and automatically the whole thing can be delivered. The whole suction evacuation. You hold the tube in a right place, and then this is a fixing of the tube. Identify the ampullary area, and this is the antimesenteric border which I'm showing, and the definite more bulge is there on that particular part. And then I use the unipolar current with the unipolar current either with the needle or with the hook. Hook is much better and stable, and you can use the vasopressin also. There is not a problem for that, and there is not much of blood. There is a minimal pelvic collection and blood there because of the congestion. The blood is there because there is no rupture found detectable either on the tube site or close to the ovary. There is nothing. A good lavage is important for the clarity of the vision, and then you use the monopolar. This is a monopolar cutting current with the hook. Monopolar cutting current with the hook. You employ that, and just with the second port. I'm going to the second port. This is the hook. This is the hook fixing the tube on one side with the atraumatic forceps and finding out the prominent area where you give a incision. This is the prominent area which I have demonstrated, antimesenteric border, and you give an incision here with the hook, and not much of not large. Don't give a large incision for that, but as because it's a longer area, it's a linear tube. I think this, and as soon as you give an incision completely, the product is visible. Now you use the suction irrigation. It's much better that you push the suction irrigation can automatically the whole POC can be expelled out for that. So this is a better method of doing that because it's a tubal mole, and you find the whole of the POC is out and there is no bleeding, and just suction irrigation is enough for that. You find there is no bleeding. If there is slightest bleeding, you put a small amount of bipolar. Otherwise, leave it as such using bipolar and don't suture it. There will be a lot of trial suturing versus non-suture. The results are all same. The even if you keep it open, there is no problem. It is all the same. And remove the tube. Just you find out and whether there is any remnants of the tissue is there or not. Don't do a fimbrial milking. Don't do a fimbrial milking. I'm doing the opposite side as because some of the uh, product could be seen here, but there is nothing inside. Now I say that it is a complete for that, and checking it with the uh, checking it with my dissector. Yes, some of the products, I think everything is done and removed with the suction evacuation. And remove that, do a good lavage, and remove this tissue. Leave it as such. I don't use advice for a stitching for that. And just with that, you remove the tissue, sent for HP study, and the post-operative period was very is uneventful. Histopathology confirmed tubal gestation, and the message here is tubal pregnancy could be without any history of missed period. That's one. So no history of missed period in this particular case. Tubal pregnancy could be there. Persistent bleeding PV with pain abdomen with empty cavity on ultrasound and raised beta HCG, suspicious of tubal pregnancy. Serum beta HCG sensitivity is as close to 100%. Conjunctive surgery, salpingotomy is definitely an option, and intact tube psychologically and otherwise also reproductive future also it's much better that you do it whenever possible. So possibility of future ectopic cannot be ruled out, though there is a lot of evidence which shows that yes, intrauterine pregnancy is possible with that, and gives a psychological satisfaction to the patient also, as I was telling. Now next situation, 30 years, para 2, abortion 1, normal cycle, pain abdomen off and on in the right side, 1.5 months. Sonographic evidence of complex tumor mass, 6 centimeter diameter, treated with antibiotics and analgesics, placentrix, persisting pain, repeat sonography, adnexal lump, 6 centimeter diameter. And we are thinking of PID with the tumor mass, uterus normal, contour, dimension. And then when beta HCG was done 500, it's a low, but it is raised. So therefore, there must be the tumor mass. It cannot be anything else other than the chronic ectopic, and DTL is done. And this is a picture where you find the right tube. There is an adhesion of momentum, and you find the right tube and ovary forming a mass, and momentum is adherent to that. Again, an old video, and there is a adhesion there of the whole tube and ovary to the ovarian fossa, and we clean it, we dissect it, taking precaution to the gut and all that. There could be, yeah, you can get a good space for that, and always dissect it from lateral side. You always don't dissect it from medial side, always dissect it from the lateral side. That's the rule in all pelvic surgery, particularly the adnexal surgery. The adnexal surgery, you do it and find it out, and there is a because it's a case of chronic ectopic, there is a adhesions on the right adnexa. You must do a good adhesiolysis first and do a salpingo-lysis right, and restore the anatomy of the tube and ovary, and then do the procedure whatever is possible, and lifting out from the infundibulopelvic ligament, and that's a routine procedure so that safety is there. Now I'm just lifting it from the infundibulopelvic. You can find it out, and gone through the ovarian fossa, and just automatically the momentum can be separated and adhesion can be released for that, and that is a better way of doing a lap surgery and technique tips and tricks for avoiding injury to the bowel, to the viscera, and any omental tissue for that. So this is, but a good space, good right cleavage has to be obtained for that, and always find out a safety plane of cleavage where you don't do any injury for that. So after doing a complete separation and salpingo-ovariolysis, then only the exact step has to be done. And this particular case has a two babies para two, and the other tube is on ovary is absolutely normal. This side patient has having a TO mass, and therefore we decided this particular case the treatment I did not only removal of the tube, but as because the tube and ovary is incorporated and forming a mass, the salpingo oophorectomy is being planned for that. So depending on the cases, you do the procedure, whether a salpingotomy or a salpingectomy or salpingo oophorectomy also. So this particular case I planned for salpingo oophorectomy, and that salpingo oophorectomy procedure post-operative period will be very, very uneventful and relieved of symptom later on. If I keep the ovary also, in this particular case, the fertility is not required, but the persistence of pain will be there, and persistent pain on that particular side will be there, and therefore I decided for the unilateral salpingo oophorectomy. And this is important that you go do a good lavage, dissection in the right plane of cleavage, and then start the procedure of removal of the tube and ovary. So before that, don't attempt for that, but it requires a little patience and time, and you can do the job easily, provided the vision is good and you can have a good technical, I mean, the gadgets available for laparoscopy for that. So these are the cases that the momentum along with the gut is adherent. Be very cautious about that. Otherwise, there could be injury on the gut for that. So if always a preventive surgery is much better than doing a complication, and then see how the separation of the momentum and bowel is done. Then it becomes very clear the whole forming a mass, and I plan for the ovary. The ovary is not visualized. The whole ovarian tube are incorporated in the mass, forming a mass, and that's why the right decision is a right salpingo oophorectomy. And it's much easier. The procedure, technical procedure of salpingectomy, salpingo-oophorectomy is not very difficult procedure. The same can be done with ectopic, with hydrosalpinx, with the tiomas, with any form and all that. The procedure is all same. But remember, a good salpingo-ovariolysis is necessary, and then only start the procedure, taking care of the precaution of the not injuring the blood bowel anywhere in that, because the bowel is also adherent and all that. So you remove first from the ovarian surface, from the ovarian bed, and the pelvic peritoneum. Then many times it is adherent to the ear also. It is adherent to the posterior surface of the uterus as well as the POD. And go laterally. Always go laterally. Here also you go laterally and then remove this the tissue and salpingo-oophorectomy. And send, of course, all the cases, as I have already told, send the patient for the specimen for the histopathological examination. And this is not a very difficult procedure, and anything with the cotter, with the mechanical cotter, or with the shear, or with this bipolar equipment and scissor, you can do a good job for that. But you go a little, you cut, coagulate more and cut little. That is the principle of the laparoscopic surgery in that. So now I find that the whole of this and only left behind is a small portion that is possible. Again, coagulate more and cut little, and then do the procedure up till the time it comes to the isthmic region, and then the things will be all right. The whole area will be clean, and patient would have a really a least post-operative discomfort or a post-operative problem for that. So these are the cases where salpingo-oophorectomy done, tissue sent for HP study, and peritoneal toileting done. Patient has an uneventful post-op period. So the message here is TO mass during reproductive period is not uncommon. Most often infective etiology resolving with conservative management. persisting pain and mass with minimally raised beta HCG. If it is less than 0.2, is less than 2 non-pregnant level, then it's all right. If it is more, even if it is less, strong suspicion of chronic ectopic. Laparoscopy is the gold standard. For this, for diagnosis and therapy, unilateral adnexectomy in contralateral healthy tube and ovary relieves the morbidity. That's very important for that. Now, this is another case, G2P1. First is spontaneous vaginal delivery. I'm reminding this case and reminding my professor, Professor U. Kananda. When I was a third year postgraduate, this was the case. Way back in 1982, this was a case in 1982. I'm reminding, unfortunately, I couldn't show the video or the photographs at that time particularly. So the case history is because I have one case which is a very memorable case and reminding of my professor. G2P1, first spontaneous vaginal delivery 6 years back, regular ANC in pre-sonographic era, having abdominal, there was no sonography, clinical diagnosis enough, and having abdominal discomfort off and on in early third trimester. She was under antenatal checkup. In 29 weeks, she complained of abdominal discomfort. It was found an oblique lie. FHS is good. Presented again at 33rd week after 4 weeks with acute pain abdomen. So after 4 weeks at 33rd week, she presented with acute pain abdomen. On examination, uterus was 32 weeks, oblique lie, and tender, and superficial fetal parts, but fetal heart is there. So that's important, and that's very important. So our clinical diagnosis was early silent rupture uterus. Early silent rupture uterus. Could it be there? There is no other gadgets. Could that seeing that superficial pelvic superficial parts, fetal parts with oblique lie, but absent but present fetal heart sound is detected. So early silent rupture fetal heart could be detected. Otherwise, if the fetal heart is not there, I would have said there is a rupture uterus for that. So plan for laparotomy immediately. 32 weeks live female fetus with intact membranes and omental adhesion all around was found peculiarly. I was really, the picture is dancing in my eyes till date also. And placenta was completely adherent to the omentum. The placenta got supply, vascular supply from the omentum. Live fetus is extracted. Placenta with membranes and cord removed along with omental tissue. We have to remove, and fortunately this was completely with omentum, not with the intestine or any vital structure. So omentectomy was done and maintaining hemostasis. No cautery was there at that time, only tying and all that, suture, and part of membranes was there adherent to the gut. So it is left behind uterus, but we could remove whole of the placenta. My professor did it and he could remove it. Uterus was bulky, no rent was found. So my professor was very much also keen to find out and explain that this is a very rare case, and uterus, you should find out the rent and previous, what is the appearance of the uterus, what is the appearance of the tube. Uterus, no rent was found. Both tubes and ovaries was healthy. Peritoneal toileting was done, and then abdomen closed in layers. Then the diagnosis of primary abdominal pregnancy was met. Baby weight was 1.7 kg. At that time, the neonatal care was not that well equipped as compared to now. And subsequently, whatever little neonatal care was there, the baby 1.7 kg, early neonatal death after 48 hours. The baby survived for 2 days and she died. Patient has an uneventful post-op recovery for that. So the message here, primary abdominal pregnancy, very uncommon. Pre-sonographic era diagnostic dilemma and only basing on the clinical sense. Laparotomy confirms the diagnosis, and fortunately, placenta could be removed along with the omentum for that. Otherwise, would have left the placenta if it is attached to any vital structures. So postoperative morbidity will be much more. Even if you give a postoperative methotrexate, the morbidity will be much more for that. So this patient was lucky that the placenta was there, but unfortunately unlucky in the sense that the baby couldn't survive for that. And this type of baby usually succumb. And this is my first and probably the last case way back in 1982, and I have not seen a single case of primary abdominal pregnancy till date also. Maybe that Nowadays, the newer gadgets are available. It is diagnosed much early and interfered much early. This particular case is a memorable case, and that's why I thought I will present this case when ectopic is being discussed way back in 1982. Now, this is another case, G3P1A1, third gavita, para 1, abortion 1, very, very educated couple. Very educated couple, an elite couple, spontaneous vaginal delivery 6 years, medical abortion 1 year ago, presented with mild bleeding PV for 10 days following 2.5 months amenorrhea. And they came with a report of sonographic evidence of cervical pregnancy, barrel sept, cervical canal with gestational sac and fetal node of 10.4 weeks with absent cardiac activity. Placental tissue was attached to the entry wall of the cervix with positive color flow. Now, cervical pregnancy, they have consulted internet and everything and all that, and consulted 3 physicians because they are very elite people, consulted 3 physicians through telemedicine. And this is a case during the corona time. This is the corona time, there are hardly the patients who are being examined, refused on WhatsApp, on telemedicine. They consulted the 3 physicians, including the Google doctor also. So they were very much apprehensive and anxious. Cervical pregnancy, whoever I think listens, they become very much anxious for that, and anxious, and from the net they could see that there could be a terrible torrential bleeding, and they arranged 3 blood donors in view of emergencies before coming to me. And then when they presented to me, I was also nervous for that. I was very much terribly nervous that cervical pregnancy and all that. On examination for abdomen, NAD, for speculum, when I put a speculum, I don't believe in this internet and in the telemedicine and advice for that. I always tell either I will see or don't see. And I examined the patient. And I told that you come and examine it. I am not, by the reports, I'm not going to interfere anything for that. When I put a speculum, for speculum examination, I find the external os was open, membrane and fleshy mass bulging out of the external os, and there was a little bleeding, not much. And there is a irresistible desire of mine when I find the fleshy mass bulging out of the external os. I with the sponge holding forceps, I just removed it with a single attempt. Everything came out, and everything came out, no bleeding, kept under observation for 24 hours, and sonography was done after 24 hours. It's absolutely normal, and discharge uneventful. Now, what is the message? I was so happy. There is a diagnostic pitfalls in cervical pregnancy. My apprehension vanished within minutes. Diagnostic pitfalls in cervical pregnancy. So, retrospectively, I find that it is not a case of cervical pregnancy. Maybe it is an intrauterine pregnancy in the process of abortion, and it has come to the cervical canal and stayed there for few days and all that. And this is what frequently happens on that. So diagnostic pitfalls in cervical pregnancy. Tech versus touch. Don't rely only on tech and telemedicine. I think always doesn't. And therefore, you combine and blend the technology along with your touch, and that is a relevance for that. Apprehension and anxiety of mind as well as for the patient. A lot of apprehension and anxiety for both doctors and patient, and disappeared within minutes for that. Because we know that cervical pregnancy, there are a lot of reports of torrential bleeding, management of all these with the tamponades and all that are possible. So this is a very interesting case, and this is not a case of cervical pregnancy, but undue credit has been given to me, the gynecologist. I took an undue credit for that, but just to show that it is not a cervical, it is a differential diagnosis, I presented this case to you. So cervical pregnancy, the diagnostic, what are the diagnostic criteria? Absence of an intrauterine pregnancy, gestational sac or placental tissue within the cervix below the internal os or uterine arteries, dilated and barrel shaped cervix, hourglass appearance, absence of sliding sign, and color Doppler findings. And the risk is uncontrolled hemorrhage for that. And the treatment modality, what are the treatment modality? Lot of literatures are there. Many cases have been reported for that. And local or systemic methotrexate is indicated in early pregnancy, less than 9 weeks, absence of cardiac activity, and serum beta hCG less than 10,000. And surgical is is warranted, but pre-op methotrexate, uterine embolization, and that helps in reducing the blood. And if there is after evacuation, if there is a blood bleeding, post-op tamponade by giving a Foley's catheter. That has been reported, and many people have given reports for that. Some people report for cervical encerclage for that, and um, this is one case which is not a cervical pregnancy. I've got a couple of cases where also the same case without, in some cases I didn't know that it's a cervical pregnancy. While evacuation there is a bleeding and it's uncontrolled bleeding, and I thought retrospectively it could be cervical pregnancy in that case. So many of the gynecologists prior to the sonography era and prior to the knowledge of cervical pregnancy must have faced many of the cases while doing a medical, I mean surgical termination of pregnancy. Some of you must have experienced that after suction evacuation, everything is there, everything is removed, but still there is a bleeding and all that. So in that particular case, that could be probably a cervical pregnancy. Those cases I remember, in many cases, I put the gauze packing and Foley's catheter to control the bleeding. And in fact, after 24 hours, everything is being settled for that. That could be probably the cervical pregnancy, which I think that because it was not diagnosed earlier, nowadays with the gadgets available, with the high resolution ultrasound. That's why I said that while doing a sonography in the transvaginal sonography, don't, apart from looking at the uterine cavity, be specific, look at the cornu, look at the cervix, cervical canal, look at the CS scar area. So these will, as we saw, more of cases we see and diagnose. Of course, if you diagnose ectopic pregnancy, cervical pregnancy, you become prepared for that, how to manage that. So there is a method, medical method, there is a surgical method, but pre-op and post-op are most important for that. Now, situation, and again another situation, Gravida 3 para 2, previous 2 LSCS, living babies with 7 weeks missed period, and sonographic evidence of CS scar pregnancy. Again, it is for the last 1 decade, we are seeing pregnancy of unknown location, and CS scar pregnancy. Cervical pregnancy was earlier being reported, but these two are the recent thing which we find. CS scar pregnancy. What is a CS scar pregnancy? And in this particular case, CS scar pregnancy of 7.2 weeks, fetal node demonstrated without cardiac activity, repeat sonography and expert opinion by 2 best sonologists. I again confirmed it, the same finding. Because it's a diagnostic dilemma, sonography. So you have to confirm that it is a CS scar, because it's not a very easy case being referred by one of my students. After that, the case is referred by one of my students, and I cannot say no to them. I had to manage, but felt nervous. Felt nervous seeing the case history. With this case history, I felt nervous more than appearing my MD exam. So I was very nervous, had to do something because it has been referred by my student. Decided for medical management. Pending surgical intervention letter if required. I counseled the patient and started the cocktail treatment. Formulated mifepristone 200 milligram followed by methotrexate 1500 milligram IM 48 hours later, followed by misoprostol 600 milligram 48 hours after that. So 6 days I consecutively give it, and followed up of this patient, admitted, hospitalized this patient, started bleeding 24 hours after misoprostol. Bleeding continuing, not alarming. Repeat scan after 1 week. After 1 week, I did a repeat scan, small mixed echogenic mass of 1.8 and to 1 centimeter. Only small echogenic mass I could see over the scar area. And declining beta hCG from 2000 to 400. So it's a I was very happy to find this, that medical management can help. And I was trying to avoid a surgical management, but repeat methotrexate I gave it after hematological profile, 50 milligram I gave it, blood stain discharge continuing for 15 days, review transvaginal sonography after 2 weeks I did it, and it was absolutely sonographically normal, beta hCG less than 2. I was very happy, resumed normal menses after 4 weeks, and my tension relieved. And then I advised, you have a previous 2 cesarean section, don't take a chance. Advised for a lap BTL after 2 months, and she did it for the last thing. So the message is, as you grow older, like me, chance to come across new and atypical cases, which will turn your hair white and reduce your lifespan. So as I grow earlier, my hairs are growing whiter and my lifespan is reducing. Seeing these type of cases and the anxiety and the tension and the risk involved in this particular case. But as a professional, as a teacher, I have maintained that. And I said that you have to do that till the last breath of your life. So few case reports and, and different modalities of treatment are there. No standardized treatment is not there in the CS scar report. Time will come when rational treatment will be revealed in due course. There are a lot of people suggesting different types of modalities of treatment. And beyond science is something which we do not know. And cesarean scar pregnancy, what is that? Let me analyze the reports and the literatures and all that and the views of the different things. Increased rate of cesarean sex and increased incidence. Now the next generation will find more increased incidence. So diagnostic pitfalls are low-lying placental implantation, cervical ectopic pregnancy, and spontaneous abortions in progress. And what is the cause of the cesarean scar pregnancy? Now, you imagine normally the placental implantation is in the low line, which can give rise to a morbid adhesion. We have seen number of cases for that, including infiltration to the bladder. And from the mid pregnancy, early pregnancy to mid pregnancy to later on also in the late pregnancy during cesarean, we have found this. And here the implantation of the placenta occurs in this cesarean section scar. This is not a cesarean scar pregnancy. So cesarean scar pregnancy is pregnancy in the scar itself. The whole pregnancy's contents will be inside the scar, and this is only in defective scar. This is not in normal scar, it doesn't happen. It's only when the scar is defective, when there is a goiter, and that is the case where it is done. And now there are some literature who say explainable to a single layer closure. Single layer closure is one of the important cause of cesarean scar, future cesarean scar pregnancy. Second important is the thickness of the myometrium. If a thicker the myometrium during suture, you do not have a good two-layer or three-layer suture, then the defect in the scar integrity will be there. And in one area, when there is a goiter and when there is a gap in scar area, the incidence of scar pregnancy is much more for that. So differentiate from implantation, low-lying placenta from cesarean scar pregnancy. That's very important, which I want to convey that. And what are the sonography criteria? Empty uterus and cervical canal, gestational sac or placental tissue in the anterior wall of uterine isthmus. I remember one of the cases came with a radiologist came with a report just 6 months back, the report of cesarean scar pregnancy. And when I saw the report and the picture also, when I saw the picture and report, with that immediately I said that it cannot be a cesarean scar pregnancy. Then the radiologist is a student of mine and is a very prominent radiologist doing ultrasound, very good and dependable radiologist. Then he talked to me, sir, it is 100% cesarean scar pregnancy. I told that it is 200% not cesarean scar pregnancy. Sir, how could you say that? I have done the ultrasound, you have not done the ultrasound. I told, you are an idiot. You may be knowledgeable, but see, you have mentioned that the placenta is implanted on the posterior surface. Cesarean scar doesn't occur in the posterior surface. So anteriorly there is a cesarean scar. If the placenta is implanted on the posterior surface, implantation low lying, it is a low lying placenta, but implanted on the posterior surface. Simply with that finding, I exclude cesarean scar. He felt ashamed, sir, it is a common sense which I lacked and reported. Henceforward, I will not report with that. And so cesarean scar pregnancy is a very, very tricky and very complicated as far as management is concerned. So gestational sac in placental tissue in the anterior wall of the uterine isthmus, discontinuity in the anterior wall, absent or diminished myometrium between gestational sac, placental tissue, and the bladder. The space is less of myometrium is there. And goals of treatment, what are the goals of treatment? Prevention of complications. One of the very important complications is the bleeding, uncontrolled bleeding. Prevention of complication, preservation of future fertility, and best approach yet to be determined. We do not know what is the best approach for that, but the surgical management is preferred over medical management. surgical management is preferred over medical management. Luckily, I did the medical management, a cocktail management in my case, in that particular case. And one case I did a surgical management by doing a laparoscopic excision and removal and suturing for that, which has been reported also. Surgical management preferred. Either they doing a hysterectomy by lap excision, laparoscopically you excise the scar and stitch it. That is one aspect. It's not very easy procedure. It's a difficult procedure, but can be done. Second, hysteroscopic removal. And when the thickness of the myometrium is more than 3 millimeter, I think hysteroscopic removal is preferable. And hysteroscope, you put the hysteroscope and remove that, and by roller ball, you can just do that. And post-operative, the medical management could be there. The same thing, I found that one literature came that it could be done by vaginal approaches. I have not tried. I will do in subsequent cases. I will definitely do this approach, vaginal approach. Doing this like a hysterectomy, when you open the anterior space, anterior pouch, you just dissect it and then find out the lower level and then excise it, remove the tissues, excise it and stitch it. That will be a very good method for that. If at all time, if I get future cases, I will do that. But of course, methotrexate and uterine embolization are subsequently helping for prevention of the bleeding for that and arrest of bleeding for that. So this is the last case which I compliment my friend Professor S.K. Giri. This is a courtesy by Professor S.K. Giri. And yesterday, when both of us were operating in a case, then I told that tomorrow, he told that I have a very interesting case. I forgot. And this case I have recorded, but I didn't find whether I could find it out. I told that at any cost you give it, and I will share your experience, and we will communicate to my viewers for that. And at 2 a.m. he saw the old film and all that. It's not able to transfer, but fortunately I could get it in the morning, and that's why luckily I would present it. My friends courtesy. This is a case of his 40-year para-2 history of abdominal hysterectomy 2 years ago. In February 2018, this case was presented to him with the post hysterectomy 2 years ago with vaginal bleeding and pain abdomen 1 week. On examination, post-speculum vault was healthy, blood stain discharge from the right angle of the vault, no pathology could be detected, PV tender lump of about 6 centimeter fell to the right fornix. So on sonography, the sonographer became very much astonished and conveyed the surgeon, and he went also, and then he was very much alarmed to see the finding, unexpected findings. And this is the findings. On sonography, clearly there is a live embryo. There is a live embryo in the vault. It was a really unexpected. Yolk sac could be seen, and the color Doppler could see the cardiac activity, and a live embryo of about 8.4 weeks could be demonstrated. And this is the video which he shared with me. And then is planned for the patient didn't opt for laparoscopy because previously the laparotomy was done, and this was the laparotomy. He did it. He is the surgeon. He did it. I wanted to share this with you, all of you. And this is a mass in the tube. This is the mass in the tube. You can find out. And this is the tube. Follow the fimbrial end of the tube along with the ovary forming a mass. And that is the. And this is the dissection part. And video is not there. The still picture are there just to share with you. And did this excision of this tube along with the ovary, and you can see the ectopic mass, gestational sac, and it's sent for histopathology. It is confirmed that it is a case of the gestational, I think, ectopic pregnancy. But the sonography has confirmed that it is a case of live fetus is there. There is no controversy about it. Live fetus, which I demonstrated for that, is very, very unusual. You see the picture for that. And this is how the message, ectopic pregnancy is possible after hysterectomy. I think this is a very rare case. Imaging signs and current diagnostic modality could reveal the rare diagnosis. And many, many thanks to my dear friend, Dr. S.K. Giri, for sharing this case report in this particular important E-Gurukul session when I'm speaking on ectopic pregnancy. And therefore, ladies and gentlemen, my last words: infertility treatment, medical, surgical increased risk factor, ART is a significant contributor. Decline in mortality and morbidity is nowadays. Early diagnosis is possible and saves life. Two diagnostic tools revolutionize the diagnosis: sonography and serum beta hCG. Newer horizons like pregnancy of unknown location, CS scar pregnancy, cervical pregnancy, heterotopic pregnancy, not uncommon. And you must keep it in mind for that. Laparoscopic approach is the mainstay and medical management in select cases for that. Thank you very much, ladies and gentlemen, and my viewers, Dr. Devan and whole of Juventus team for giving me again opportunity after a gap of 2 months, the 12th episode. Thank you very much, all of you.
Thank you so much, sir, for such a lovely and engaging conversation. It was really pleasure to always to listen to you. And as we were discussing, there were 413 viewers online today, and there are so many questions today that it's going to take more time. We are not going to leave you very soon, sir.
All right, I'm there.
Right, sir. So I'll bring across a few queries to begin with. This is the first query, which is coming from, one second. Yeah, this is coming from Dr. Prabhat Tripathi. As I told you that even before your session started, there were two queries. So one of them was medical management of ectopic pregnancy. He was very keen, and I think he must have been quite satisfied, with the results by now. And Dr. Seema Kaushal, she wanted clarity on use of injection methotrexate, its risks and management. So these are two queries which in fact were there before you started the lecture.
Well, I have already categorized that medical management methotrexate is the drug of choice, but the contraindications for methotrexate therapy like impaired liver, impaired kidney, renal functions, and hematological profile must be done for that.
Right.
And this is for multi-dose treatment. If you are giving a multiple dose, this is absolutely more important than a single dose, particularly for that. And you have to select the cases. Which are the criteria for medical management is completely different depending on the sonograph, the ectopic mass, size of the mass, and the beta hCG level. This is important to find out, and absence of the fetal heart. I think these are all, if you select the cases, I think methotrexate can be given, but remember, counseling is important. I have shown one case where I've given a methotrexate with the fulfilled criteria, but still after 3 days, she presented with acute peripheral circulatory failure with acute rupture. So that must be kept in mind for that.
And the next question is from Bhagalpur, from Dr. Pratibha Singh. What about auto transfusion in case of, in this case, yeah, so she was referring to your initial cases where you had done you had demonstrated those auto transfusions which are done. So she's also keen in knowing that, can all this be done in usual routine cases?
Long back, we started this procedure when we were doing a laparotomy also. When laparoscopy was not very common. In my hospital also, we did a couple of cases of the auto transfusion. See, separately, a separate team has to be there for that. And remember, the blood in the peritoneal cavity in ectopic pregnancy are mixed with blood clot and blood. So in that particular case, initially, we used to filter it and clots separately, and then putting it on that. Then the method came when the idea came that if we can, there is a filter in the transfusion bottle, and in the transfusion bottle with the other end, if with the 50 cc or 100 cc syringe, we can put it through the transfusion bottle, the filter separates it and we can put it for that. So a separate team has to be there, and we bring the bottle from the Red Cross blood bank with the reagent, with the anticoagulant is there, and then prepare that. It will take a little time, but it less time than bringing blood from the blood bank for that. And depending on the amount of blood deposited, we can get, I have the maximum, I get 1 unit minimum and 4 units maximum in my life. And I've shown that about 13 cases I did it. And remember, when we switched over to laparoscopy, it is much better that in laparoscopy you get easier and rapidly you can just do a procedure. you put the suction irrigation cannula, and with the 100 ml syringe, you draw it and locate it at a particular place where the clots are not there. That's a very important thing.
Correct.
More of the clots, less of the blood means you get less amount of blood. But it is a good technique for that. If better supportive than supportive to the blood arrangement, particularly from the blood bank, because the major advantage is a 100% cross match.
And
And Pratibha,
definitely, sir.
I have still remembered you presenting one case with auto transfusion. I
Yes.
remember one of the conference in Bihar Jharkhand Society BSOG conference. You presented one. I still remember, and I have also supported that, and my experience also with that.
So that was erythropoietin. Actually, we had launched, and it is still there with us. Yeah, we are promoting it. Sir, but especially I think this is very useful when it is a rare blood group and the patient cannot arrange for other
Particularly
donors.
if it is a negative
Negative.
blood group. I think is the first priority for
Yes,
that.
definitely.
AB blood group, AB negative blood group. That's important.
Correct, sir. Then, sir, the next query is from Kolkata from Dr. TK Guchet, saying that if one fallopian tube lose because of ectopic pregnancy, what are the chances of pregnancy in future?
Pardon. Again.
If one of the fallopian tube is lost, so what are the lost because of ectopic pregnancy? So what are the chances of pregnancy in future?
I think it's a very difficult question to be answered, because I cannot. I'm not an astrologer or a Baba Mama to predict that this is there. Neither having a mathematical model that this much percentage and all that. But there is a fair chance, and report says that about 50% of the cases we see the interrupted pregnancy could be there when if they provided the other tube is absolutely normal.
Okay, there is another query from Dr. Dinesh Bhatta from Karnataka, Bangalore. He's saying that, sir, in case two, you had shown that in the series that case two, was there peritoneal pneumonia or I don't know, pneumo, she has written, I don't know,
Peritoneal.
pneumo,
Oh,
peritoneal pneumo.
yeah. The case two was a rupture following medical management. We have done a medical management, but there is an acute rupture, and you mean to say that whether pneumoperitoneum can be done or not? Yes,
Yes, sir.
that's a very important question, because the whole of the abdomen is tense, tender, and all that, and all full fluid, all the fluids are there for that. There is a little difficulty in creating pneumoperitoneum in a case where it's a totally bulging for that, and the intestines are there for that. So, but you cannot have full 3 liters of gas inside, and even if you get a 1.5 liters with that also, you can do anymore. You can do the puncture for that. And believe me, in those particular cases, it's better to have the port, safety port. I think the safety port is much better in that particular case, so that the chances of injury to the bowel is not there.
Right. Um, Another question which is coming, I think, which you have explained several times by now. Dr. Manse from Bhubaneswar, she's asking, like, how you perform the auto transfusion.
Yeah, and that's what I tell. That separate team is there. It's not a routine procedure of, as you said, in rare instances where the patient is not able to bring blood, or the rare blood group and all that, we are doing that. And therefore, I have only 13 cases in total for that. So in laparoscopy, I have already told that yes, select the area where the blood is there, the clots, avoid the area where the clots are not there. And with the syringe, in a 100 ml syringe in the blood, you connect it, and obtain from the blood bank, Red Cross blood bank. We bring the anticoagulant bottle along with that, and there is a in the transfusion. I think the transfusion cannula, the connecting thing. There is a separate. Unlike the infusion set and the transfusion set are completely different. Transfusion set, there is a filter, and through that filter you just collect it, and use another filter, another transfusion set for the giving a transfusion. That is all required for that.
Okay, sir. When you explained about the tuberculosis case, now Dr. Poonam Gupta from Delhi is asking, in India, is it more prudent to send a portion of tube for gene expert for Mycobacterium tuberculosis?
Well, tuberculosis may be a cause of pelvic inflammatory disease and infertility, as well as ectopic could be there also. But if there is a suspicion, you can find out, you can do this, send it for a specimen. Otherwise, routinely, it's not necessary for that.
Okay. So what are the measures one has to do?
Because I have seen, why I am asking, because I have seen, I have a strong debate with another great person where he told that any ectopic postoperative, I give a therapeutic trial of anti-tuberculosis treatment for 3 months. I contradict that. I am not in that opinion of giving empirically anti-tubercular treatment for 3 months in all ectopic pregnancies, presuming that all ectopic is due to tuberculosis for that.
So there's Dr. Nikhila Agate from Maharashtra. She's near Pune, Palegaon. She's asking, is milking of fallopian tubes advised so as to save the fallopian tubes?
Well, earlier it was done. Earlier it was being done in fembryal pregnancy or in a tubal abortion. So in that case, just whatever tissue is left behind prior conception, you try to expel it from the fembryal end by that. Now, later on, it is seen that milking is contraindicated. Milking one should not do because in milking, there is a damage to the tube and interior and risk of future pregnancy, ectopic pregnancy is there, number one. Number two, by doing a milking, the fresh bleeding will be there from the inside, and you have to do after milking also, you have to do a salpingectomy for that.
Okay, sir, from Bhubaneswar again.
Yeah.
You want to take a break, sir, or something like? Should we take a small break or something?
No.
Any queries like today?
No. Finish
Okay.
it.
Okay. Sir, in situation one, continuation of pregnancy after general anesthesia at the very early gestation has any effect or due to anesthetic medication on embryo?
No, well, if you just I'm reminding about the teratogenesis, theory of teratogenesis and embryo toxicity and all that. We know that very vital is if it done before 7 weeks, 7 to 9 weeks is a very important period of embryonic affection for that. So if it is a very early, not there is least chance, and if it is a chance by chance between 7 to 9 weeks, there is a possibility. But you cannot say majority of the cases there won't be any problem for that. Because we do not know the real fact or the cause of embryogenesis or the teratogenesis particular for that. So as because it's very early, we continued and we find that there is no effect for that.
Right, sir. So there's a query regarding mifeprostone. This is from Manipur, Imphal, Dr. Purnima Nepram. She's asking dose of mifepristone for medical management of ectopic pregnancy.
We see, you always methotrexate is a priority for that. Mifepristone, I say that the cocktail treatment for scissor and scarp, ectopic, and all that. That I gave methotrexate, mifepristone 200 milligram only, not more than that, 200 milligram, and again misoprostol 600 milligram. So mifepristone 200, you can, I don't have any experience on increasing dose of mifepristone, but alone mifepristone also doesn't act. So you have to, methotrexate is the first line of management. To supplement it, I cocktail it.
Okay, sir. Another query from Meghalaya, Dr. Clarinda Edna Kongwar. She's asking how to tackle a 12-week cornual pregnancy.
12 cornual pregnancy interstitial, because this is a cornual or interstitial pregnancy presents very late. About 12 to 16 weeks also it can grow because it doesn't rupture because the myometrium is there for that. So the same technique is there. Segmental, I think cornual resection is the method. It's not a cornuostomy. Less than 12 weeks you do a cornuostomy, but more than that, it is a cornual resection. You do it even at 16 weeks also. If you find an interstitial or cornual pregnancy, you do a cornual resection, but a good suturing has to be done for that. And therefore, I have given importance and repeatedly told that suturing is mandatory for future myometrial correction of the defect or future chance of prevention of rupture uterus.
Okay, so Dr. Manoj Kumar Sahu from Orissa asking why absent cardiac activity is a criteria for methotrexate therapy.
See, because methotrexate is not going to, when cardiac activity is there, it's a active fetus. It is an active placental, and there the chances of failure is much more by medical management for that. So therefore, medical management is there, and some authors have done a potassium chloride sonographic infusion under sonography guidance. That KCL they infuse it, stop the cardiac activity, then they start methotrexate for that.
Sir, again, Dr. Manoj, no, sorry, it is Dr. Santosh Behra from Orissa.
Hmm.
Of course, he's saying that, sir, you are making surgeries look very simple, you know. So, but
He's my friend.
so it says, but actually, if there is a lot of bleeding, um, so can the hysterectomy be an option?
Well, hysterectomy can be an option if there is a comorbidities. There are other associated pathology of the uterus. There is no doubt about it. And patient completed the family, and this could be another option. And as say, for example, cesarean scar ectopic or a cervical pregnancy, there even hysterectomy is an option for that, because life is important for that. If it is not there, hysterectomy can be done, and you have to resort to
Yeah.
hysterectomy as a life-saving measure.
Um, as many others are, Dr. Maya Padi is also a big fan. So from Katak only.
Yeah, my
So
favorite.
saying that excellent presentation backed by demonstrations of unusual cases and impeccable surgery, amazing and usual. So this is a comment she wanted.
See, this is a on white for that, and what is the purpose? I must transfer it, and that's why I told you surgical skill transfer. Maybe good, maybe bad, maybe a good surgery, maybe bad, but whatever I have learnt it, the mistake or the positive point, I must ventilate to the next generation so that they will grow much better than me and
Yeah,
excel me.
of course. So from Jharkhand, Dr. Neha Priya, she's asking, can this bipolar damage the ovarian tissue? If in that case, what to do?
Yeah, certainly bipolar, the energy can damage it, but bipolar damages less than the monopolar and seals much better than the monopolar. So in ovarian pregnancy, you have to do it. I think there is no other options for that also. So in majority of the cases, even in endometriosis, even in other surgery also, we do a bipolar coagulation, but don't char it. Remember that if the bipolar is used for arrest of bleeding. So with a low voltage, you make it, and just as long as the charring is not there, your main purpose is coagulation and arrest of bleeding.
Okay.
Many people, what they do, they char it, they make it black, repeated places, in multiple places they apply the bipolar. You locate the area where there's a bleeding, and just with the one scope it is completed.
Sir, again from Katak, Dr. Manoranjan Mahapatra, asking two queries. One, that whether single dose of methotrexate should be given to a patient diagnosed with liver ectopic awaiting surgery.
Karan, with
Single dose of methotrexate, can it be given to the patients diagnosed with live ectopic, with live ectopic
like
awaiting surgery?
in the
Yeah.
live ectopic pregnancy, medical management is contraindicated, as I have already told. Again, I will not recommend for that, because the failure is more, and if at all it is advisable, then you have to give a KCL, and then methotrexate can be tried pending surgical intervention for that.
Right. And the second part is that routine S&E during ectopic surgery, your opinion?
Routine suction evacuation? No.
Yes.
I think the case where you find the only case I demonstrated about the heterotopic pregnancy, when there is a intrauterine fetal death of both, there I did the routine, I did the suction evacuation and sent the specimen for the histopathology to confirm it. Otherwise, routinely, when you know that it's a ectopic pregnancy, you should not do it. Second indication, is in pregnancy of unknown location. When there is a PUL, there is a place for diagnostic curettage or even aspiration and histopathology examination to exclude that it is not a case of intrauterine pregnancy. That's important for that. Third, in cases when we were students, our teachers were telling, and this is the routine practice at that time. And this query also was there in my mind, in that after doing a surgery, they do it just to arrest the bleeding, because after the surgery, because the endometrium has an area still reaction, the endometrial thickness is more, they used to have a constant bleeding for few days. So to arrest that bleeding, one can do curettage, but otherwise normally I don't recommend the curettage for that in inciting infections and other things.
Again, there are two parts further from the same person. One is that what is your opinion on retrieval of tissue through the POD when it cannot be retrieved through 5 port?
Now, POD is a very good option for that, but that we routinely employ in a larger tissue. In a larger tissue, in a dermoid, in a big ovarian cyst, or in a myoma also, rather than doing the morcellation, we remove it to that POD for that. But for ectopic, usually it is not necessary because the tissue is not much. Maybe that if it is a pregnancy in a rudimentary horn, non-communicating horn, about 14, 16 week size and all that, that you can employ for that. So size, if it increases, large size, large volume, and that you can deliver it from the POD, collotomy and all that.
And says that does the incidence of pelvic inflammatory disease increases in POD retrieval?
POD retrieval, it doesn't increase. It doesn't increase because you are under vision, you are doing it. The contraindication should be there. If the POD is nice, you can do it. If the POD is really earlier, the POD, lot of cases have an endometriosis. Lot of cases have a infection, pre-existing pelvic infection where there is adhesions. You don't do it there, because by doing that, you are aggravating again adhesions for that. Otherwise, if it is a clean cut cul-de-sac, you can do that.
So there are actually 5 or 6 requests which have come where people are asking about the procedure of auto transfusion, So probably we may cover this as a topic in some of the future.
Yeah, yeah.
Yeah. So the next query is coming, which is like uh, contralateral ovarian chocolate cyst, left side with pelvic endometriosis grade 3. With right ectopic, whether surgery for endometriosis should be done concurrently or not.
Now, ectopic is an emergency diagnosis, an emergency disease. Endometriosis is not an emergency disease. So I think the priority should be given for ectopic. In the same sitting, I don't advise the procedure for that, because the ectopic conservative surgery, if you are doing it, there is likelihood of bleeding. And in pregnancy state, ectopic pregnancy also, there is a lot of congestion and chances of bleeding will be more. So therefore, I will not recommend the cystectomy in the same sitting for that while doing an ectopic pregnancy for that.
You have explained the scar pregnancy in detail, and people are asking again that what is your experience on scar pregnancy?
Cesarean scar pregnancy, I have already told that it was not being known. 10 years, last 10 years, we are knowing the two entities, the cesarean scar and cervical pregnancy. Cervical pregnancy was earlier there in the books we are reading. But the diagnostic difficulty was there in the cervical pregnancy, because, as I have already told, the nowadays the good man and machine can diagnose the cervical pregnancy. So just imagine, I have also experienced many cases of suction evacuation for termination of pregnancy, and there is a torrential bleeding. That could be a cervical pregnancy, a cesarean scar pregnancy, could be possible for that. And retrospectively, now we think that these are could be possible cervical pregnancy or a cesarean scar pregnancy for that. Now, because the things are, the gadgets are there, good resolution, high resolution sonography machine are there, along with color Doppler, we can pinpoint the diagnosis of cesarean scar pregnancy or cervical pregnancy. Therefore, I have not much of experience on that. Cesarean scar pregnancy, as I have already told, medical management, whatever 2, 3 cases I have done with the cesarean scar pregnancy, where one case I did with the surgical, as I have already told, that laparoscopic excision of the scar pregnancy and retrieval, that I have done one case, and 2 cases medical management I did it. And cervical pregnancy, the pseudo cervical pregnancy, which I told that I took an undue credit, that elite couple, they told that yes, you are a god, but ultimately I find that it's an intrauterine pregnancy in a process of expulsion. I just removed it. Cervical pregnancy. It's not a true cervical pregnancy. But cervical pregnancy, apart from it, I have another 2 cases which I experienced, and those 2 cases have a torrential bleeding, which could be arrested by Foley's catheter for that for 24 hours, and the patient was all right for that.
That's good. Um, so there's another query like tubal abortion, and does it lead to secondary abdominal pregnancy problem?
Yeah, secondary abdominal pregnancy, either it could be tubal abortion with a live pregnancy or active pregnancy, or majority of the tubal secondary abdominal pregnancy are because of the rupture, perforation, and then from the tube it goes, and then intra. If it comes to the intraligamentary, it's a broad ligament. It comes to the antimesenteric border, it becomes abdominal. So usually majority of the cases are due to early rupture and implantation and continuation of the pregnancy.
Right. Sir, this mifepristone, is there a role of this drug in cesarean section scar pregnancy without cardiac activity in the particular case that you have mentioned in your studies?
No, the report shows that methotrexate is still the thing, and I, in that particular case, desperately, I did an experimentation with the cocktail regimen, with the cocktail. So methotrexate, mifepristone, and misoprostol combiningly. So meaning thereby that if you give a mifepristone along with the methotrexate, I think the vascularity will be reduced, so that the chance of bleeding will be least. That is the only purpose for which I tried for that.
I think this was the question which you have just explained. Why this cocktail? This is question asked by Dr. Kusum Dash from Jharkhand. So I think
Yeah.
you have very nicely explained it. I don't need to repeat it now. Um, then there's a query like that is from Orissa, that in early pregnancy, low level of serum beta HCG and urine pregnancy test is faint positive, but no intrauterine pregnancy. And then beta HCG starts declining in next week. So how to explain this to the patient?
Remember, beta HCG is a very strong biochemical marker of pregnancy. If it is more than, if it is less than 2, you can say that it's not pregnant. If it is marginally elevated also, it is pregnancy. And either it is in the process of spontaneous resolution, or in a case of pregnancy of unknown location, with the sonographic evidence that not demonstrating anything for that. And declining level of beta HCG is a reassuring sign for that it is in the process of spontaneous resolution, and there the expectant management can be managed for that.
So there are only two more questions. And one is from Dr. Shalu Jain from Delhi. She's saying, as per your own experience, whether single or multiple dose of methotrexate is better.
See, I have both experience of single dose as well as the multiple dose also. If I give that there is a significant drop in a persistent trophoblastic disease, particularly if I do a conjugative procedure and then give it, single dose is enough for that. But if I'm doing for a medical management, I think in that particular case, the 2 doses are minimum required for that also. And very rarely I have to give another third dose for that, not beyond third dose.
Right. So the final question is from Dr. Purnima Nipram from Imphal. She's saying that, sir, is it necessary to conduct DNC after the ectopic operation?
That's what the same question I replied. The DNC is not routinely mandatory for that. The DNC was a diagnostic gadget They recommended in books also, in textbook also it is written DNC and endometrial biopsy to confirm and differentiate PUL from probable the intrauterine pregnancy. So that is the only thing. And to arrest bleeding, which you might expect for a longer time, that for area reaction and all that, you just do a DNC, but routine DNC is not at all recommended.
Right. So with this, sir, we only now left to thank you and give you some voice rest.
Thank you very much for.
Thank you very much. It was such a pleasure talking to you, sir, and listening to your great experiences.
Almost 3 hours. I think I have bored all of you for 3 hours.
But sir,
I have taken permission for 2 hours, 2 hours, 6 to 8, but it is going to be 9 o'clock. I'm really thankful to my viewers for your patience. I know that obstetricians have much of patience, but current generation of obstetricians have more patience I could find from this session of ectopic pregnancy under Juventus. I think I must again thank all of them for watching it, sharing it, and I think you also have to share your own experience, because as we grow older, multiple things and multiple experiences we must share with each other.
I think it's a very good suggestion. So we request all the viewers to keep sharing their experiences. You got our email ID. You can share on email ID, or you can send us any WhatsApp message also. Live message also can be sent. And we'll try that. We'll link it up with Dr. Mahapatra, and he could help us in.
I think that is a very important thing, which the sharing of knowledge is important for that also.
Right.
So in our profession, medical profession, see, nobody is great. I think you must learn from everybody for that.
Sure.
And I'm a learner till my last breath. I will continue to learn from that. And these are the persons who will teach me.
Right.
So that is the thing which I believe as a teacher.
Thank you very much, sir, for your
patience.
Thank you.
Your devotion, your dedication and all that. After a gap of 2 months, again, revival. I thought people have forgotten me as well as the E-Gurukul, or they must be thinking that I am in a ventilator. Why he is not seeing for last 2 months? But now they are seeing me. I am alive. I'm not in a ventilator. I'm totally non-COVID, and I'm still active, and I will continue to be involved in the profession of teaching and treatment till my last breath.
So we pray that your blessing should always be there on us. Thank you very much, sir. Thank you very much. We wish you a very, very good luck and health.
So, Dr. Divan sir and Mahapatra sir, there were 417 viewers who were listening to you constantly for 3 hours, sir.
Thank you. Thank you. They have a lot of patience. I must congratulate their patience.
And today from the medical team, we had special attendees, Dr. Sanjay Navle, as well as
Dr. He came before time.
Yes.
Sanjay came before time. I think I'm seeing you for the first time. Congratulations and welcome to the Juventus team.
So, and
no, sir. Last time I was there.
Oh, you are there. I thought I've forgotten that.
And Dr. Gandhi is also there. So I think they will be participating more in future.
And one digital expert is going to join you in the near future. You told. I think it will be better for us as well as for the viewers for that.
Sure. Thank you.
Because we want that all the episodes should be in the teaching platform for that.
Right, sir.
Because this request from many of my students, many of my colleagues, that we want to have all the episodes as and when required. We'll watch.
Even today, sir, at least 5 or 6 requests are there that they were attending it as a first session and they wanted all the previous recordings.
Thank you.
Sir. Thank you very much.
Thank you. Bye bye. Good night.
Bye, sir.
Thank you, sir.
Thank you. Thank you. Thank you. After a long time, I'm seeing your face.